So
Yes, sir.
this is Case of the Month, episode 6. So as all of you know, at the Bangalore Skull-Base Institute, Bangalore Cochlear Implant Institute, what we do is organize what we call Case of the Month, which represents the most important and interesting case of the month. So what we are doing is showing you this particular case that was, according to us, one of the star cases that we did in the month of April 2021. So at the Bangalore Skull-Base Institute, we do a fairly large number of skull-base cases. And in the last month, we did about 7-8 cases. And one of the most interesting cases that we did last month involved this particular patient that came down to us from Iraq, who was diagnosed to have Petrous bone cholestoma, for whom we had to do a petrosectomy, transcochlear petrosectomy, and the patient was willing for an Osia implant, and Osia implant is one of the latest implants in the portfolio of implants by Cochlear, and we were fortunate enough to be able to do one of the first Osias for skull-base surgery in the whole of Asia Pacific at our center, the Bangalore Cochlear Skull-Base Institute, Bangalore Cochlear Implant Institute. And along with this, we offered facial plastic solutions, which was the part of the surgery which was headed by my dear friend and colleague Vishwas, who is an eminent facial plastic surgeon, and I think one of the best hands in facial plastic surgery today in India. And it's been a privilege for me to work with him. It's a pleasure for us to invite all of you to this episode of the Case of the Month. And going forward, we will have Ganga, who is our fellow from World Skull-Base Foundation. She's here with us for 1 month, a very keen learner, a keen student of skull-base surgery. Ganga has already finished her fellowship diploma in World Skull-Base Fellowship Diploma last year, and she has now joined Bangalore Skull-Base Institute as a fellow in skull-base surgery. So Ganga will take you through the first set of proceedings, which involves case discussion, following which Vishwas will take us through the facial plastic part of it, after which I will step in to discuss the surgical aspects of the excision of Petrous bone cholestoma. And then we will deal with Osia implantation. So can you go back a couple of one slide, please? Go back one slide. Yes. So I would like to introduce Vishwas. So Vishwas did his fellowship in skull-base in facial plastic surgery from UK, and he was a Commonwealth fellow there, and he did his training under some very eminent European facial plastic surgeons. He is right now working at Transcochlear Hospital as a consultant facial cosmetic and reconstructive surgeon. His special interest is facial and paralysis management. And as I told you, Vishwas and I studied together in Manipal University in Bangalore, and we know each other for a very long time. And it's a proud feeling for me to be sharing stage with him, and in fact operating with him in this particular case. We have done several cases before together, and this one I think is one of those cases that tops the list, and I'm sure Vishwas will agree with me. So I welcome Vishwas to this episode. Thanks for your time and for all the valuable inputs that you'll be giving us through this presentation.
Thank you, sir. So, thank you for inviting me over.
Thank you, Vishwas. So you will be speaking about the entire facial plastic management after the case presentation by Ganga. So now the floor is open to Ganga to do the case presentation and to discuss briefly about the subject, Petrous bone cholestoma. Ganga is, as I told you, she's done her fellowship diploma with us at World Skull-Base in lateral skull-base surgery. She is now a World Skull-Base Foundation trainee at Bangalore Skull-Base Institute deployed by, I would say, World Skull Base Foundation, and she's doing a 1-year fellowship in skull base surgery. She's, as I told you, a very keen learner, and she has fantastic skills, and I hope and wish that going forward she will be a fantastic skull base surgeon. Yes, Ganga, so you can go ahead and take over the presentation. Thank you.
Thank you for the opportunity, sir. Yes, so I would like to start with the etiopathogenesis and then followed by radiology. Surgical approaches would be spoken by Dr. Sampath and Dr. Vishwas. So here are the case details of a 28-year-old male who had complaints of right ear pain and scanty ear discharge over a year, and history of decreased hearing in right ear for 12 years and history of right facial nerve paralysis for 12 years. So it started with the first surgery, which was in 2010, and it was for CSOM, where probably a minimal cortical mastectomy was done for extensive cholesteatoma. The case was abandoned, and subsequently post-surgery, he developed House-Brackman grade 6 facial nerve palsy. So in 2014, first attempt was made at facial nerve repair, and that was temporalis sling to upper lid, lower lid, and modulus. And a resurgery was done in 2017 to attach temporalis sling to modulus. Here is the otoendoscopic view of the same patient, and it shows that there is grade 3 retraction pocket in pars flaccida and pars tensa with granulations in the anterior superior quadrant. Coming to the investigations, we did a Putone audiometry, which showed a right 90 decibel profound hearing loss, and with the left sided normal hearing sensitivity of 15 decibel. And a video nystagmography was done, and which showed normal smooth pursuit, normal saccades. And apart from this, we also tested optokinetic tests, spontaneous nystagmus, gaze fixation and without fixation, and positional test and head shake test, all were normal. And we also did a nerve conduction study where we tested for the zygomatic orbicularis oculi and nasalis. As you can see here, left had maximal response everywhere, and the right one had minimal response, showing severe right facial axonopathy. So coming to the clinical facial nerve examination, this is a sequence which we follow in our institute for facial nerve monitoring. And yes, so as you can see here, it is pictures taken in series where it's taken at rest and with closed smile, and show the third picture is with showing teeth, and this is a nasal basal view and with eyebrows, forehead raising, and with the eyes closed gently and then eyes closed tightly, and again the basal view, and with the pouting or puckering of lips, and then this is with wrinkling of nose and showing the lower teeth. And this is how we examine the facial nerve clinically. And you can see here that it is a grade 6 facial palsy can be observed. And coming to the other cranial nerve examination, as you can see here, this we have tested for the glossopharyngeal and vagus cranial nerve, and it's found to be intact. The gag reflex is normal. And coming to the 11th cranial nerve examination, that's spinal axis nerve, it is normal shrugging of shoulders is present. And coming to the 12th cranial nerve examination, the tongue movements are normal, as you can see here. So coming to the radiological investigations, we had done a pre-op CT scan showing the axial HRCT through the temporal bone. I will just guide you quickly through it. And as you can see here, there is yes, you can see the mastoid. There's slight opacity on the right side. And as we progress, we can see that there is a hypodense lesion medial to the jugular bulb. Yes. And here you can see that it's medial to the jugular bulb. You can see the soft tissue density, and the jugular bulb is intact. There's no erosion there. However, the erosion in the tegmen tympani region and the hypodense lesion is seen in the middle ear cavity as well. And it is medial to the cochlea, and as you can see here, and you can see that it's involving the genu, the vertical part of carotid, as well as the horizontal part, and extending into the internal auditory meatus. As you can see here, left side it is normal, and right side it's there's a lesion involving the internal auditory meatus. So coming to the pre-op MRI, this is a T2 sequence, what we can see. And as you can see here, you can see a hyper intense lesion, what you can see, medial to the jugular bulb. Yes, as you can see here, medial to the jugular bulb, and also involving the carotid. That's the, yes. So this is medial to the jugular bulb. Here is the lesion, what you can see, and this is the carotid artery. And you can see it's involving all around the carotid artery. The genu, vertical and horizontal part is also involved, as you can see subsequently, and extending further into the internal auditory meatus. And into the Petrous apex. So coming to the T1 weighted imaging. As you can see here, there will be hypo-intense lesion, what you can see. Here, a large hypo-intense lesion involving the horizontal part of the carotid artery and medial to the jugular bulb, and extending into the Petrous apex and internal auditory meatus. So we had not done a contrast enhanced MRI for the reason it was already being diagnosed as a Petrous apex cholesteatoma. So the surgery plan was right-sided transaortic approach with infratemporal fossa approach type B extension for Petrous bone cholesteatoma removal with blind sac closure and with upper lid gold weight lid loading, lateral canthal canthopexy, facial microfat grafting with Osia implantation under general anesthesia. So the surgical approaches would be discussed in detail in some time. So I would like to discuss the radiological aspect of the operation. And this is the post-op HRCT axial cut, what we are showing you. And here, as you can see, it's a transcochlear petrosectomy scenario. And you can see that it is filled with the autographed fat. And it's extending well up to the Petrous apex. And you can see here that we have removed the majority of the, we have cleared majority of the Petrous bone, and a small part is just retained with entire disc clearance throughout. And this is the sphenoid sinus part, the Petrous bone close to the sphenoid sinus. And the carotid is also exposed here, as you can see in this region, and the jugular bulb is preserved, as in this case. As you can see here, the jugular bulb is preserved with the bare carotid area, carotid artery. And also, as you can see here, throughout the film, you can see an artifact in the retroauricular region, and that is because of the bony artifact, the artifact from the BI 300 implant, and also the coil, the magnetic coil of the transducer. So there's multiple artifacts which has to be considered when you are going in for imaging. So coming to the post-op facial nerve examination, there is no much difference in the facial nerve function. However, because of the excellent facial aesthetic surgery, you can see that he's able to close his eyelid, which would be further discussed by Dr. Vishwas. So as we discussed with the symptoms and otoscopy, audiology, and radiology, we would quickly brush through the management aspect. So before that, I would like to discuss a few points about Petrous bone cholesteatoma. It is a slow-growing expansile lesion, and these epidermoid lesions are they are the epidermoid lesions of the Petrous portion of the temporal bone. Etiology can be congenital, acquired, or iatrogenic. And we have our very own classification for Petrous bone cholesteatoma, and that is Senna classification, and that has 5 types. That is supralabyrinthine, infralabyrinthine apical, massive and apical, and subclassification with the cholesteatomas extending into clivus, sphenoid, and nasopharynx, and intradural extensions. So the supra, quickly let me brush up with the classification. The class 1 is centered around the geniculate ganglion area where the facial nerve and anterior epitympanum. And the class 2 infralabyrinthine is mainly centered on the infracochlear, infralabyrinthine, and hypotympanic cells. And the infralabyrinthine apical, where the extension is into the Petrous apex along with infralabyrinthine. And massive is centered on the otic capsule, and the apical is centered along the Petrous apex. So coming to the main topic of our webinar series, that's Osia system. So what is Osia system? So Osia system is a new hearing implant which is developed by Cochlear, and it is a special, it uses a special piezo power transducer that expands and contracts to create powerful vibration, and it can be used in for a better sound transmission to the inner ear. So the parts of the Osia system is the speech processor, which has the battery and the dual microphone. And also it has the second part is the transducer that along with the active implant and a small titanium implant. And these two are connected with the digital RF link. So let us see how it works. So it works how the process of that is the sound processor captures sound in the air and digitally analyzes the signal that is through the radio frequency wave, and the process signal and power move through the skin into the implant, and this is the magnetic coil which holds it, and the vibrations are transferred to the active implant, that's the piezo power transducer, and when this vibrates, it is transmitted to the small implant, that's BI 300 what we have used, and the vibrations are transmitted directly to the inner ear, and hence sound is perceived. So it is, the studies have shown that Osia users show a significant improvement in their ability to understand speech in quiet and in noisy environments. So the studies have shown that there's 12 decibel improvement in the speech and noise perception, and the speech perception in quiet background also there's a significant improvement. So what are the advantages? So the basic audiological criteria for Osia is there should be an airborne gap of more than 30 decibels with the sensory neural element less than 55 decibels. So the potential benefits, what we can expect from Osia system is conductive loss is bypassed, ear canal is left open and nothing in or on the ear, and as a result, there is less need for amplification, and there's less aggravation of otitis media and otitis externa, and there is consistent hearing even during episodes of ear infection. So what are the advantages for the surgical aspect? So there is simplified coil insertion, no recess is required, and no risk of coil migration. Ideally, CT scan we do, but generally there's no preoperative CT scan per se required. Minimal master drilling and minimal risk for dura exposure. So what are the benefits for the patients? So there's a digital sound experience giving the patient hearing of highest quality. It has smart sound IQ driven processor which enhances speech, reduces noise and increases comfort. And there is excellent speech recognition in noise and in quiet environment. So the surgical aspect, the facial aesthetic aspect, I would like Dr. Vishwas to carry forward. Thank you.
Vishwas, over to you,
Ganga.
and
That was a
you can
very
take over from now.
eloquent presentation. Thank you, sir. That was Ganga, I have known for a very long time now. She's been a very passionate ENT surgeon and also an accomplished Veena player. She excels in whatever she takes up, and she's a very dear friend. And I'm so happy that she is training under one of my best mentors that I had in my postgraduate days, and that was Sampath sir. I think she is really lucky to be doing her fellowship in the Skull Base Institute, and she'll be a fine surgeon one day, and I wish her all the best. Sampath sir, can I share my screen?
Yes. Give me 1 second. Okay. So we are trying to
Post disabled participant screen sharing.
correct.
I can pass the slide to Ganga because it's a small slide, it's not much.
Now we are not able to add you for okay. No, you have to stop sharing. That's okay. So now only if you stop sharing. No, that's not the case.
Yes, sir, I can see my screen now.
Yes, can you share? Are you able to share? Oh, okay.
Yes.
Yes, got it. Perfect.
A very good evening to everybody who's joined in today. I can see a lot of familiar faces. Dr. Srinivas, I know from KMC Bangalore, he's a head and neck fellow. And many others joined in today. A very special mention today is to my senior teacher, Sampath sir, who's made this day and time possible for a unique combination that has not happened across the world ever. You are actually witnessing history in the making. Sir, should I stop?
No. We are trying to record. Give me 1 second. Okay. Okay. You can go ahead, Vishwas. We are
Can you
trying
hear
to record. Me? Yeah, I can hear you. We're just
Can you
trying
see
to record. Yes. Okay. Right. Perfect. Okay. Go ahead, Vishwas. All fine.
Yeah. Is my audio clear, sir?
Yes. Audio is clear. There's a slight lag. There's a slight lag, but it's clear.
Okay. So this is something that I wanted to dedicate to Sampath sir, because this is a unique thing that is happening first time in the world, wherein we are combining skull-based surgery and facial plastic surgery. It all started about, say, 14 years back when sir guided me to achieve better paradigms and to create a space for myself and an identity for myself. From the day one, he was always motivating me for excellence and doing something special for the patient. I have learned a lot of surgeries from him, but one thing that I have learned profoundly is his enthusiasm to learn better, work better, and improve himself at every step. We have met constantly at various intervals, and one particular incident that I need to mention, I think it was the 𝐒𝐤𝐻 conference in 2012, and I could be there thankfully for a fellowship that was granted by the ENT UK. Same time, Dr. Sampath sir was there with Dr. Mario Sana, and the amount of understanding and the kind of learning that used to happen between the disciple and his master was something to watch out for. And it was a treat to all of us to learn how every step was important in the grooming of a student. Hopefully, we will be great teachers like you, sir, one day. It is just a matter of learning from you at every step. And this initiative that we have had today, wherein we combine skull base and facial plastic, is something which is going to go into the books of history, wherein we are going to introduce this concept across the world so that more and more centers can take it up. That's why I feel it was a match made in Manipal and executed in Bangalore. And hopefully this will continue for many, many years to come.
Absolutely, Vishwas. Thank you for your kind words, and no greater pride than teaming up, as I told you before, with a colleague and a dear friend. We were together several years back, and then we parted ways. You took on your course. I went on to do a few other things. So, and then to come back to a city like Bangalore and to team up again is such a phenomenal experience. I'm sure if you'd asked us 10 years back whether we would be doing this, I'm sure both of us would probably, not be very sure about this, because you took up spatial plastics, I took up skull base, and then, as you said, it's a well-made match. And today we are together, and I'm really proud and privileged to be working with a top-class facial plastic surgeon like you. And yes, we have. I think it's the first few steps in a long journey. And I think we have to innovate. We have to innovate, and that's what we are doing. And hopefully, this pair, this team, and all that we have kind of built around us is going to show some tremendous results in the years to come. Thank you, Vishwas, and it's again a pride and a privilege to be teaming up with you and working with you.
Thank you, sir. I mean, I mentioned all this because I'm sure there are many fellows who are listening to us right now with dreams in their eyes and looking forward to a future beyond the pandemic and trying to see what lies ahead. You can follow our pathways, and you can see how after 14 years we have reached to this point wherein we are able to combine our skills ultimately for the patient. Everything should be for the patient. And that's what I have been learning time and again from great teachers like Dr. Deepak Haldipur, Dr. Vijendra, Dr. Madkeri, Dr. Sampath sir, and many more in our own state. Hopefully, we will all continue to inspire and be inspired. So let me begin with my area of interest, that is facial plastic surgery. I have been enamored by facial emotions from a very, very long time. And that also happens to be the basis of this particular presentations. Because of these emotions, we give a lot of importance to the nerve that helps carry these emotions. And because of these emotions, we can communicate, converse, and at the same time express our feelings, desires, and everything across the world. Without these expressions, we are actually disabled. Only when a person goes through a facial paralysis, he knows the amount of emotional trauma that passes through his mind, which further prevents him from emoting. Because if I were to tell you, all your emotions come from the emotional circuitry, or rather the frontal lobe, but not the volitional pathway or the cortical matter. So whenever you want to emote, you don't actually think about it. It just normally flows down the facial nerve. And what happens many times is when a patient gets his facial nerve paralyzed, there's a lot of negativity in his mind, seeing his own face, which is drooping, or his eyelids not able to close. That builds up a lot of negative feeling. And that negative feeling automatically tries to block off the flow of further emotional neural circuitry via the facial nerve. So it kind of is a cascading effect wherein the negative emotion, by seeing his own deformed face, further prevents the flow of normal facial emotions across the facial nerve. I hope I'm able to cut across to all of you listening there the very meaning of facial emotion via the facial nerve. And that's the reason we have to give maximum importance to the facial nerve. And facial nerve is actually that fine rope on which Dr. Sampath and me are balancing across and trying to reach our patient objectives. So why did we actually combine to do these procedures together? The first thing, as I did mention to you, was the patient comfort, because having the patient under one procedure and finishing both the resection as well as giving him an aesthetic outlook would have been the best outcome that anybody can promise the patient. Now, an anesthesia procedure in all is going to be an experience to undergo. But if the patient is going to undergo 2 anesthetic procedures and then be sick at the end of it, he would rather have 1 anesthetic procedure wherein he can get out of the anesthesia and be done with both the procedures. The most important thing I learned out of this exercise of having 2 surgeons operate at the same time is about surgeons optimizing the space. So to say, all us surgeons, we have a lot of egos, and hopefully we have limited our egos in the real time. The advantage to the patient is the decision making. For an example, if I am assuming that there is a plan which I have made before I get into surgery, and I will do the facial plastic procedures accordingly, and in case there is an unplanned catastrophe, let's say the facial nerve gets injured whenever you're doing a facial nerve transfer or a translocation, and then you immediately have a person ready to help you out and make sure that the patient gets the best outcome. At the same time, cancers never listen to the scans. You do the scan and then you go inside and then you see a totally different picture many times, or the cancer would have eroded into various corners where you can't even, or you wouldn't have even planned. So having a facial plastic backup for a skull-based team would be very beneficial in the long run. Now, by going through this approach, we are trying to challenge the limits and trying to see if the 2 spectrums, one is the resective spectrum and other is the aesthetic spectrum, are able to come onto a single platform and deliver better. And this, I'm sure, makes us grow as team players, and as team players, as time has gone by and told us many times over, we grow on each other. I think with this, I can proceed on to our patient who has kindly consented to get his photograph shared and for better learning. I hope and wish that you do not take photographs from the screen and not share it across, because that would be amounting to his breach of privacy. I'm sure this is going to appear on YouTube or elsewhere later with the kind permission of the patient after documentation. Until then, I would request you to keep it safely in your phones. So this is that wonderful patient who actually allowed us to think beyond our normal routine and go further and explore what else we could do to improve his life. So because of his multiple surgeries that were done in 2010 and later, and in 2014 and 16, he had been left behind with this deformity. Sir, Sampath sir, if I can request you, there are 6 people listening in, including Ganga. If I can, or have them unmuted so that I can get their feedback as I'm going ahead, it would be more interactive rather than I speaking all the time. Can I do that, sir?
Yes. We will get to unmute everybody. Taufik, you're the host, right? Is Taufik listening? Yeah, so myself and Ganga are unmuted. You unmute yourself. You can unmute yourself as well. Okay, so since we both are in the same room, Ganga is with me. Since we both are in the same room and the computers are in the same room, there'll be an echo. So I'll keep Ganga muted, although she is right here with me, and the others have to unmute themselves. So whoever is here can unmute yourself so that we can have a live interaction with Dr. Vishwas and make the session more interesting.
Right. I mean, leaving alone all the cholesteatoma and all that inside. Now I actually want the fellows and the attendees to concentrate on the face part itself, because the facial nerve is not just about aesthetics, it is also about the function. So if you can unmute yourself and tell the points that you think are abnormal in this patient's face, we would be happy to carry on and add to your observations. Dr. Srinivas, you would want to start off?
Hello. Yes, sir. So, what I have to exactly say? Can you please repeat your question?
Anybody in this fellow group
so we
or
can't
the
hear you.
attendees?
1 second.
Anybody in the fellow group or in the attendees, they can observe the photograph that I put up there and comment on what deformities they see there, so that I can add
Sir,
to that.
the photo, we can only see you. We can't see any photo. Have you shared your screen, sir?
Yeah, screen share is on. Did it go out? I'm sorry.
We can see only you. We can't see any screen. Yes, now.
Is it clear now?
Yes, sir.
Okay, I'm sorry. So the patient's face you're seeing in right now, what all deformities can you observe is something that I want the fellows to come out with, because I don't want this to be just a one-way traffic. If you can contribute, I would be happy to add to your information. Anybody
So
wants to?
Right-sided facial deformity, what we can observe here. So
Okay.
starting from the forehead, we can see that the forehead crease. Left side it is fine, and right side you can see it's reduced. Faint,
Okay.
I can see. So that's one thing. And the eyes, obviously, he's not able to completely close it. And coming to the nose, that's the alar region, the nasolabial fold. Again, there is a sagging on the right side. And also, I can see some sort of depression in the temporal, the zygomaticotemporal region, and also in the malar region as well. Yes, sir, over there. And yes, so the lips also, I can see slight asymmetry there.
Excellent observations, Ganga. Anybody else wants to comment?
I see the nasolabial fold is also lost in the right side.
Excellent observation, sir. Anybody else wants to comment?
No. That was Kanu. Kanulal Saha is an associate professor due to become a professor at Bangabandhu Sheikh Mujibur Rahman University in Dhaka, a very dear friend. And welcome you, Kanu. Great to see you here. You and your team. I see a few other people from Bangladesh as well. Tariq is here. Welcome to both of you. Yeah, Kanu, make session interesting. Go ahead and communicate. Okay. So we're all waiting to hear from you as well. And I'm sure
Thank you,
Sam. Yes.
Thank you.
Right. So if I can add to your observations, Kanu sir. So there are a few more things I just want to mention. If you can look at the position of the brow, the eyebrow on the right side seems to be lifted up, which is in contradiction to what our observation is. Now that actually is a after effect of this surgery, which was done in 2014. So what was this surgery that was done in 2014? Was a temporalis muzzle transfer to the upper lid and the lower lid, so that the upper lid and lower lid move by the action of the temporalis muzzle. And also this temporalis muzzle sling has been brought down to the modulus. Can you see my cursor as
Yes.
I'm moving? Yeah. So the temporalis muzzle is also brought down to the modulus to move the lip. So the after effects of it is, one, because the skin has got pulled in here, the lateral brow has got lifted up, contradicting our thought that the brow has to be depressed. Though of course you can see that there is absence of the forehead creases. The second point that you need to be observing is, of course, there is a limitation of eye closure, and that is more so nearer the medial canthus. Now, whenever there is an eye closure defect more near the medial canthus or the medial direction, it is not only the upper lid problem, it is also the lower lid problem, which means to say the lower lid tone is lost sufficiently and thereby the closure is not complete. So what this leaves behind to the patient is the punctum is never able to approximate across the globe, and thereby the tears that are generated are never sucked into the nasolacrimal duct, and thereby what happens is there will be excessive tearing. And because of this open eye or lag of thalamus, the patient will also experience some amount of scleral congestion and possibly a bit of corneal dryness, thereby resulting in excess production of the tears. So there's a twofold factor for the excess tearing, and that was one of his predominant complaints. He said, "Doctor, I'm unable to watch TV for a long time or mobile for a long time or drive out because my eyes keep tearing." Now, this hollowness is an effect of the atrophy that happens after the temporalis transfer. Now, normally in a temporalis transfer, what happens is muzzle slings are taken under the zygomatic bone and tunneled way across to the modulus. So the modulus is a point where the zygomaticus major, zygomaticus minor, depressor anguli, all of them collude. And based on the direction of pull, if the zygomaticus pulls in this direction, the smile comes up. If the depressor or anguli oris pulls in this direction, the frown comes up. So each muscle acts in tandem with varying grade of propensity to produce the facial expression. So the modulus is a very important dynamic point which allows the smile or the expression on the face to come up. And this surgery was in vogue for a very long time, and it was by a French surgeon, Daniel Lebe, who described it, and it still is practiced for patients who are having no other option left for surgical improvement. That is, if you cannot improve by any other means, this would be the last resort. The reason being of the asymmetry that is created on the temporalis part, that is more evident than the facial paralysis itself. This is one thing. Many patients lose hair after a temporalis transfer. Third, as I already told you, modulus is a very, very significant point for movement up and down. Now, the modulus can move in multi directions, up, down, sideways, angulated, based on the type of muscle that is attached. Now, by attaching only one sling to it, you are giving only a unidirectional pull to it. So the only expression that he can get would be the smile. If you can see my face, can you see my face, sir?
Yes, we
Yeah.
can. Yes.
Yeah. So the only thing you would get is this one smile, and you would not be able to do any other expression. And that's why this procedure is now reserved for patients who are like the last resort. You have to do this. Okay, we don't use this procedure much these days, but one factor that is most important to do this procedure is to have the functioning fifth nerve intact. If in a skull base procedure you are going to cut or remove the fifth cranial nerve, then there is no point in doing this procedure. So that also becomes a contraindication or a limitation. Now, this is the view from the side. The observations, of course, you can make is the temporal hollowing is there. Along with that, you can see there is flattening of the face as mentioned by Dr. Ganga. The nasolabial fold crease is absent, and you can see a fine scar that is there on the nasolabial fold. This is the scar which was done during the 2014 surgery and the 18 surgery, wherein they pulled the modulus, the muscle sling through this and attached it to the modulus. So this would be the access route for pulling the temporal sling. Now, one thing you can notice from the side is the eyes look mostly normal. But if you go close, I'm not sure if I have that photograph here. I might show another photograph later as Dr. Sampath sir is doing his presentation. There is a well which is there in the lateral canthus, because if you can see my photograph, there has been a sling attachment across the lid up and down. So this sling has never sat on the bone. So it is actually sitting lower down. So it is opening up the lid crease like this, and there is a well available laterally wherein the tears can sit. In fact, I'll explain to you this later, but for now, it's just for our understanding. So this is the patient from the normal side. You can see the nasolabial crease, the alar crease being normal, the forehead crease being there, no scars. Now, this is the attempted smile. Now, when a patient who has had a temporalis muscle transfer smiles, he has to smile in a particular way by what we call is the chewing smile, because the temporalis is driven by a chew or a bite. He has to kind of, whenever he wants to smile, chew. Can you see my action? He has to chew to get the muzzle moving. That is what has happened here, that he's tried to bite his teeth. That's when the smile comes up. When he bites his teeth, the fifth cranial nerve gets activated and the temporalis gets activated and pulls this angle, and that's the smile you're seeing. And the dimpling, what you're seeing here, is the place where the attachment has been made. So the skin is also getting tucked in along with it, causing the dimpling. But you can see that the temporalis has been a failure for the eye. The reason being, the temporalis is driven by the bite. So whenever you're biting, so if there is a sling attached to the eye, if you are biting, your eyes will also close. So that is an unwanted effect, and that is one of the reasons we do not do the Lebes procedure very frequently for all patients. I hope I'm clear till now, all the fellows and attendees and Professor Kanu listening in.
Absolutely fine so far. Very clear.
Yes, sir. Yes, sir. So now when a patient presents like this and he is come to you for counseling, he has three questions in mind usually. One, will you be able to improve the symmetry of my face? That will be the first question that any patient will ask you, because our aesthetic sense is bigger than our functional sense, because by now, after 6 years of surgery, he somehow managed to close the eye or to smile or to speak meaningful words. First thing is he'll ask you about symmetry. Second thing, he will ask you about the function, that is the tearing of the eyes. That is a lot of tears come rolling down when he is seeing the movie, or there is a fan blowing into his face. The third thing that he might ask is whether my smile can be improved. And these were the typical questions he also asked. And thankfully, his parents were with him, who also gave additional perspectives to me on the emotional aspects. So what they told me was, he is not a very expressive person, but everybody loves his smile. So to a facial plastic surgeon, when they tell that, we need to actually factor in a lot of additional information, because our mind or the brain has a lot of imagery of ourselves. When we look at the mirror, we actually like something about our own face. And supposedly so, this patient here liked his own smile. Now, coming to a surgeon like me who is able to give various surgical procedures on the face, now I have to think, am I going to be a great surgeon trying to do great procedures and improve the smile a little bit more, or I should leave him to practice that bite driven smile, which he has been doing for a long time. So this question, I actually put it back to him, and he said that I do not want anything big procedure here, but if you can improve my symmetry and my eye closure, I would be happier. So I repeatedly asked him whether anything has to be done at the smile. He said, doctor, if you can remove the dimple, what is there, by improving the symmetry, then I would be happy to go ahead. So the reason I asked him about the smile is there are various procedures, which I might just show you a slide later, wherein we connect the fifth cranial nerve to the seventh cranial nerve, or we connect the normal seventh cranial nerve via the sural nerve to this side cranial nerve and allow it to smile simultaneously. So what I'm trying to explain is there are other procedures which can also allow him to smile. Now, this question stayed with me, and then we wanted to find out whether even if I do those additional or other procedures, whether his other muscles which have been dormant so far, that is the zygomaticus major, minor, depressor anguli, are they still active? Are they still alive? If I bring in electricity across using a wire to the bulb, is the bulb still active? Was the question that was running in my mind. So what I did, I went in for an electroneuronography and an electromyography. So with this, the information that we get is whether the nerve is acting on the right side, whether the nerve is acting on the left side, how is the muscle motion on the right side and how is the muscle motion on the left side in comparative basis, because here he has unilateral facial palsy. What we understood from the muscle study is the muscles are not at all active. So that also brings to the point that even if I get a nerve across the face, the seventh cranial nerve, and attached to the various branches of facial nerve here, the muscles are not at all alive. So there's no point in doing that additional procedure or getting the fifth cranial nerve. So then, after ruling out the possibility of a nerve transfer, the next thing that I asked him was whether he is okay with a muscle transfer. So what do you mean by a muscle transfer? That is, you get a new muscle, that is a new bulb. You anyway are planning to put a wire, that is the seventh cranial nerve, across the lip and put this new muscle here so that the muscle pulls the lip. So he asked me two questions pertinently. He said, doctor, what does it involve? That involves taking out that gracilis muscle from the thigh and putting it up here so that it moves. And he asked me, what are the chances of success? He said, I said, there is 70% chance of success. So his question then was, how much of improvement I will see over this smile, whatever I'm getting now with the bite? So I told him there will be a very marginal improvement and not a very great improvement. The reason being, again, the gracilis has to be attached to the modulus only. It cannot be attached to the various muscles, depressor and all that. It has to be attached to the modulus only. And again, this will add to the bulk of the face, because the gracilis muscle, what we add to the face, is going to add 18 grams to 20 grams approximately. So it's going to add bulk to this part of the face. If you actually look at it, it is an advantage in the terms of symmetry because there is flattening of the face. But the bulk will be more here in the pretragal area because you're going to attach it to the zygoma and then bring it down to the modulus to get the correct direction. So the bulk will be here, which is unwarranted, and it will create more asymmetry because there is hollowing here and there will be an artificial bulge here. So considering all this, we decided to skip the smile procedure. So the next thing was his concern about the eye, the closure of the eye and the tearing. So I did explain that there are 3 to 4 types of procedure, of which the upper lid would best benefit by something we call as the lid loading. What do you mean by lid loading? Whenever you put an implant or any heavy weight on the lid, because of the gravity, the eye as it moves down it moves completely down. Whatever motion happens, because the orbicularis is like a valve, it goes like this both ways. But once the valve stops acting, or the sphincteric action stops acting, the lower lid everts and the upper lid stays where it has to stay. So the point then is to put a load or a weight on the upper lid to pull it down or move it down so that it goes across the cornea to the lower limbus. Now, if you just correct the upper lid and do not correct the lower lid is everted out. So the punctum is everted out. So you want it to invert inside as well as come closer to the upper lid so that the closure is complete when the patient attempts a eye closure. I hope I am clear till now, whoever is listening in.
Absolutely, absolutely. Brilliant, Vishwas. Very, very engrossed in whatever you're saying. Thank you.
Yes, sir. Thank you. So I told to him that there are two kinds of procedures that we are planning. One is for the upper lid and one is for the lower lid. Now, the limiting factor for me as a surgeon is that he has already undergone a sling out there, which is attached to his muzzle, orbicularis muzzle, and another sling down to the lower lid. So my advice to him was, if I find that the sling is coming in the way of our procedure, I will have to cut it and remove it, and at the same time sacrifice it. Anyway, it is not giving you a great benefit of eye closure, and it is counterproductive, because whenever there is a chew, you get your eyes to close, which is not healthy. And that would almost become like a synkinetic motion, wherein we have a jaw winking. When you try to smile, your eyes goes like that. So this is what the patient agreed upon. So now I already told you from our earlier observation that there is a medial canthal angle which is exposed more as compared to the lateral canthal angle. Now this medial canthal angle would mean that this part is also a lot lax than this part. That means the orbicularis bundle here is not as much innervated as this one, and that's why the medial canthus is more visible, and you need to strengthen this. So the ideal procedure for this would be to do a medial canthopexy to tighten this. Okay, but there is a classification which says if your punctum is within the limbal margin, you can still get away with doing a lateral canthopexy. If it has reached up to the limbal point, it is better you do a medial canthopexy as well as a lateral canthopexy along or with something we call as a facial sling. So you have a sling, facial lateral sling attached inwards here and attached to the infraorbital margin here to get the eyes to move up or the sling to move up or the pulley to come up like that. So this is what we planned, but since he had punctum which was inward of the limbus and not nearer the limbus, I decided to go only with the lateral procedure. Are you able to hear me, sir?
There was a brief period when there was a lag in your voice, but now it's sorted out. Looks like it's okay now.
Okay. So I told him that the lateral procedure is the only thing that we will have to do. In that, again, there are two kinds of procedure called as tarsorrhaphy and then canthoplasty. Without confusing all of you much, it is basically meant to say that the lesion which can be reversed or can be retained, and that would be what we have designed over the time is lateral canthal canthopexy. So in canthoplasty, what we do is we find the tarsal plate and then the lateral canthal tendon, we cut it and then again pull it and attach it to the infraorbital margin. Whereas in canthopexy, whatever tarsal plate and the lateral canthal tendon is there, we only pull it using the help of sutures to attach it to the infraorbital rim. So if you can imagine my hand, what I'm trying to explain is, in canthoplasty, you cut a portion of the lateral canthal tendon and take it out, thereby shortening it and then tying it together so that it gets anyway pulled. Whereas in canthopexy, you fold the canthal tendon upon itself to pull the lateral canthal tendon and attach it to the infective procedure, which has been abundant across facial plastic surgery and is done only in an emergency setting when you feel that the corneal exposure is causing macula, whatever, the corneal erosions. That involves attaching the gray line and causing a symblepharon, or something we call as a synechia. So what happens is the lateral part closes like this, and thereby the tearing and all that will reduce. But trust me, it is visible from a distance and it looks very, very awkward. Is that clear, sir?
Absolutely. Yeah, it's clear, although there was a little bit of a lag as you spoke in the last, I would say 2 minutes. But yeah, the gist of it is clear. Yes, we got most of it, if not all of it.
Okay.
Hello?
The reason I'm explaining all this, sir, is once you... So the point of next is the facial asymmetry is what the patient was concerned about. And that, if you can see here, the marked out areas, there is hollowing in the malar area, there is hollowing in the paranasal area, there is more hollowing in the infraorbital area, as well as there is hollowing in the temporalis. So out of this, he was concerned most about this part here and this part lower down here. So the suggested procedures for the asymmetry are again 3 number. 1, you can have an implant put into place to augment this area. Another, you can have a filler put into this place to augment this area. Third is something more natural, and what we have in abundance is fat itself. And he agreed for fat, and in that there are 3 kinds of fat: fat pockets, or rather packets, microfat and nanofat. The best survival of fat, even though there is a atrophy of 30%, is by the microfat, which helps in augmenting the cheek area and at the same time the subcutaneous and soft tissues. So the estimated volume which was required to fill up this much was 15 ml, and we were able to gather about 17 ml totally. Now, coming to the upper lid procedure, I want you to notice one thing is, during the procedure, we mark out these 3 lines. So the central line is the mid-pupillary line. The reason being, when the eye is closed during your procedure, you do not know what is the exact center to place your implant. If you see, this is a gold implant, which is 24 karat without any impurities. The reason being, it is very inert. It does not react with tissues, and the chances of infection are very, very low. Also, the gold matches with the color of our skin, especially in India. And that is also one of the reasons is it is moldable on table, so that you can mold it according to the shape of the tarsal plate. Now, what would be the ideal weight to be put on the gold implant is, you need to measure it pre-operatively with certain standard silver measures, which ranges from 0.8, 1 gram, 1.2, 1.4, 1.6, 1.8. Most of our patients require between 1.2 grams to 1.6 gram. It's very rare that we go for a 1.8 gram. Now, this gold implant has 3 holes placed in a tripod fashion. The lower hole is towards the lower margin, that is towards the lid margin, and the upper 2 holes are towards the levator. So the surgical procedure itself is a standard blepharoplasty approach in the supratarsal crease, wherein you go at a distance of 8 millimeters from the lash margin in males and 6 millimeter from the lash margin in females, for the reason that the supratarsal crease are at different lines. Once you go across, you will encounter the orbicularis muscle, which you need to cut across using a sharp pointed cautery or a monopolar cautery at very low current settings at 7 settings. And once you incise it, you will be able to appreciate the tarsal plate. One word of advice is any point of bleed, immediately just buzz it with a bipolar cautery, again at a very low setting. Once you reach upon the tarsal plate, there is a very thin layer behind the orbicularis oculi and between the tarsal plate and that, which has to be incised to reach upon the cartilage part of the tarsal plate. And that thin layer is avascular, just like the gossamer thin fascia, what you see in thyroids, you see in various other dissections in soft tissue. And that's very crucial because dissection of that pocket has to be very precise for you to fit this gold implant in place. You do not want to open up a big pocket and then place the gold implant, because the gold implant can tilt based on its weight in any direction. We want the weight to only go down as per its weighing proportion. So that's why that pocket, what you create on the avascular plane, is extremely important, not to go beyond a limit. One word of caution is, now the levator palpebrae superioris comes like this and attaches to the tarsal plate. Now when you are going from the orbicularis ocular division and cutting it, you have to go across to the tarsal plate here rather than going at the junction. Now, if you go at the junction and cut between the tarsal plate and the levator palpebrae, you are going to weaken the tarsal plate even more. So once you weaken the tarsal plate, what is going to happen is you are also going to add a lot of gold implant there. You have already weakened the tarsal plate levator pull. The third nerve pull is not there. So there is a good motion of the upper lid, which you will be very happy about. You will tell, wow, superb motion. But the drawback is there will be ptosis. So the patient's pupil, which is there, will get covered by this falling tarsal plate because you have weakened the levator palpebrae. So you have to be extremely careful not to get the cautery or the incision or your scissors into the junction point between the levator and the tarsal plate, which usually attaches to the superior most part and to part of the anterior part of the tarsal plate. So try to stay mid zone in the tarsal plate, only dissect till there and make a good pocket, go down until you see the hair follicles of the lashes, and that would be the ideal pocket to be put. Use a 6-0 Prolene on a round body needle to attach the tarsal plate. Always take care not to move your needle too quickly because you can perforate the cornea while you pass the needle. So you always have to be careful for that. Of course, use corneal protectors so that you do not damage the cornea in process. So the molding has to be done as you place it and see how it is. It is usually comes pre-molded from the manufacturer who has been given the specifications for the angulation, but you still can mold it based on the contour of the tarsal plate. Why I'm mentioning this is, if somebody has had a facial paralysis for a very long time, the tarsal plate will also have hardened and the direction and the angulation would have changed. That's why we need to mold it on table also. So once you put the tarsal plate, the gold implant on the tarsal plate, you start closing the layer of orbicularis and start closing the skin as well with simple stitches, which you remove at the end of 7th to 10th day. So the other procedure on the lower lid, what I mentioned, was the lateral canthal canthopexy. Now, if you can see here, it has been demonstrated here. What we do is, I make a small incision with a 11 number knife after infiltration, of course, and then take a double needle suture. That is a 5-0 Prolene on a round body. This is very specific. We cannot handle with any other kind of needle. And then pass the suture into that hole, engage the lateral canthal tendon. Both the needles are brought out here. Once both the needles are brought out here, you expose the infraorbital margin using the same upper blepharoplasty incision, make a hole in the infraorbital margin while being careful not to get into the orbital fat pads, and then suture the threads through the hole and tighten it. Once you tighten it, the lower lid is automatically going to move up, and this gap here is also going to close. The direction should be always most vertical, because only then you will get a plication of that lateral canthal tendon, which I did mention. If you put it here, you will only get a pull and this area will open up. You want this area to close. The most important point when you're putting this suture here is it always has to be from inside out. You always have to take the suture from inside out. That will make sure that the lid sits snug to the globe. If you do not take it inside out, it always creates though it tightens up, it creates a small pocket there, which is not a great thing. And then you close this incision as I mentioned earlier. So I hope the eye is clear, and then I can move to the next step of the facial symmetry.
Absolutely. Fantastic.
Yes,
we are with you.
yes, sir. So now the source of our fat is the abdomen, which would be the best source. The reason being the stem cells are more and it helps in regenerating the fat. And that would be especially the infraumbilical location. That's why when you paint the patient, you need to paint from the xiphisternum onwards directly onto the inguinal region, then the medial thigh region and the lateral thigh region. The reason being, this patient did not have much of fat, and that's why we had to access these additional areas for fat. Thankfully, he did not have much fat when I put the cannula in, but Dr. Sampath found a treasure mine of fat inside on the incision. So anyway, what is usually done for a fat harvest via the liposuction cannulas is you prepare a solution of 500 ml ringolactate, 30 ml of plain 2% lignocaine, 1 ampule of adrenaline, and 3 ml of soda bicarb. This is a standard solution used for liposuction. The reason being, you have to put the solution for one is patient comfort, one is so that your cannula can move front and back, one is for the hemostasis. If you are doing the patient under local anesthesia, this would be very, very comfortable to the patient. And you ideally, if you want to take 30 ml of fat, you need to inject about 60 ml of solution inside the cavity. So there is a certain technique how you infiltrate. You have to hold the abdomen up or the abdominal wall up and infiltrate, because if you do not hold it up, you are likely to perforate onto the peritoneum and go into the visceral cavity. So you should hold it up and infiltrate in the fan-like fashion. Unfortunately, I don't have the photos here. I have the video which I can show a little later. Sorry. So the motion for removing the fat or after the infiltration is somewhat like a seesaw motion, and you maintain pressure with a 10 ml Luer lock syringe, which gives the adequate pressure to bring out the fat pockets along with the serum, along with whatever you have injected. So once you keep getting the fat out, you take it from various regions. There is a lot of surgical techniques to this, but then for the paucity of time and so that you have more interest in this, I want you to study more. You draw out the fat, and then once you draw out the fat, you cap it. You cap it and keep it like this, so that these layers, what you're seeing here is, one is the serum, then you have the fat, and then you have the liquefied layer. This is of course after the centrifugation has been done for the fat, so the layers have separated. Now the top layer is not useful, the lower layer is not useful for us. So what we do is we decant it. We remove the lower bloody layer and the serum and the lignocaine, whatever infiltration you have done. Can you see it pouring out? And then the top layer of oily layer is there. We put a neuropathy inside and suck out the oily layer. So the pure fat is left behind, which contains the stem cells also. Now this has to be transferred onto our infiltrating syringes using something called as a luer to luer transfer. Now, if you are doing this, you usually transfer fat packets into microfat. There are additional filters called as nanofilters for other procedures like facial rejuvenation, surface rejuvenation, and all that, wherein you have nanofilters. When you push across, you send the nano fat only, and the other thicker stroma remains behind. So that's how we usually filter the fat. Now, once I've transferred it to a 2 ml syringe, I mark out all the areas where I had to get the fat in. Now, you also have to mark where you infiltrate, or rather the points of entry. So one of the predominant points of entry is near the nasolabial fold, then near the malar area to access the temporal hollow and the mid cheek point. Reason being, these are devoid of vessels, and this would be the most easy to access and push the fat. So first you need to put a 18 gauge cannula, make a pathway, then have your infiltrating cannula, and it says my internet connection is unstable.
Yes, yes, we can hear you again. Just a few seconds back, there was a lag.
Sir,
There is a lag in your audio, but now I think the
I
audio.
got a phone call.
Yeah, I think it's because the phone call. The last time also, the problems happened after the phone came. So I think it's something to do with the radiation of the phone. Anyway, so we are able to hear you now.
Yes,
It's all fine now. Your video
okay,
was frozen for a second. Now that's opened up. Now I think your voice also is fairly okay now. I think it's fine.
right, sir. So the infiltration points are what I've shown in. Deposit only 0.1 ml at a time, and you have to deposit not during injection but during withdrawal. So you need to deposit packets of fat during your withdrawal and not during pushing the injection needle inside. And it has to be deposited onto the subcutaneous plane separately, under the muscle separately, and onto the bone and supraperiosteum. This is how we need to do a layered augmentation to get the fat augmentation. So this is the post-operative photograph after 5 days, which was taken in the ward. I hope I can see him now. Unfortunately, I think he has some COVID infected parents. That's why we're not able to see him. So the eye closure is what you can see at this point is complete, and the swelling on the face, you can see it is better. So that is giving a zone of symmetry. The nasolabial fold is not there because that was never our purpose. And you can see that there is a lateral swelling as well. So now whenever we create a symmetrical face, we need to always augment it more by 30% because that amount of fat is going to atrophy anyway. So considering that, you have to overdo it and then allow it to settle down. So this is the view from the front and this is the view from below. You can see that we have over augmented the right side, and the eye movement, you can see that the eye movement is good now. But if the patient tilts his head back too much, the gold lid implant is going to take it backward. It's like a doll's eye. So always you need to assess in the neutral position or in the basal view to know how much of the motion is there and not much of ptosis is there. So this is the view from below, I think. Yeah. So I think with this, I've just finished briefly what we did that day. Of course, we took almost 6 hours on this, and thankfully Sampath sir waited for his procedure to start and we could do a complete job. Open to questions now, and I wish and hope that some of you at least take up facial plastic and do come along, and I'll be happy to teach you all. So
can I apply with yours? Can I apply? I would love to learn facial plastics, although age is not on my side, but so that's the reason why I have this ulterior motive of bringing you down to some of my cases. So I learned the facial plastics, but no, I don't think I have such fine fingers as you have. Facial plastics requires a sense of aesthetics, fine fingers, finesse. I think we are more crude, rough surgeons, like the way you mentioned about fat. You took such beautiful amount of fat in such a painstaking fashion, whereas we had to, when we took our fat out, it was chop, 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 and pretty gross, I would say. So yes, wonderful, wonderful work, Vishwas, and wonderful presentation. I listened to every word that you had to say, and it's I've heard you before, but this topic was new to me, and I learned a lot of things. Although it's always fantastic to learn new things. I'm not sure if I'll be able to do any of these things, but it's always nice to know what you're doing, what others are doing, to update ourselves. Brilliant, brilliant things that go on in the facial plastic world, and in India, and I'm sure in the world too. I think you put yourself right on top, and the things that you do, that I have seen you doing, is right on top. And we are really, really privileged at Bangalore Skull-Base Institute to be working with you. I'm sorry if I interrupted something. You were supposed to show one more slide. If that was the case, I'm sorry. Hello, we can't hear you. Taufik, if you're the moderator there, can you, Vishwas has one last slide to show, and he has a couple of things to say.
I unmuted myself.
Yes, now.
So this was just, I'm sorry. This was one of the patients whom we operated together, sir. So this was a patient who had a paralysis, which was short term, and we had to take this real-time decision intra-op to reroute the nerve and to get additional anastomosis from the fifth cranial nerve. I think this was done at Manipal Hospital, and then we took this decision to do an anastomosis between the seventh cranial nerve and the fifth cranial nerve. So this is the upper buccal branch that you can see here going in this direction.
Vishwas, you have to share your screen all over again. I'm sorry.
Oh, I'm sorry, sir.
Exit and share it all over again. Full screen, please.
Yeah.
Yes. Perfect.
Yes, sir. So this was the surgery which we did. The reason I put up this slide was this was a real-time decision that we had to take, because you said it is very difficult to keep the nerve intact because the tumor had involved it, though that was not our plan initially. And this is what we could do immediately, because we had access to all the high-end microscope and the nerve monitoring and the nerve stimulation. So the fifth cranial nerve is found within the mesenteric bundle near the sigmoid notch, and then brought out by cutting it lower down as much as possible, and then anastomosed using a 9010 ethylon under micro neuroanastomosis under the microscope. And this is the upper buccal branch which has been anastomosed with the fifth cranial nerve. The reason I put up this slide is, now the brain is such a wonderful organ, is when you actually anastomose the fifth and the seventh cranial nerve. So again, it would be a bite-driven smile. So you will have to teach your brain to consciously smile. So if I see a joke or a comedy, every time I'll have to bite and then the smile comes up. But the beauty of this fifth to seventh cranial nerve is, if you train the patient very well, slowly the volitional stimulus that you give to chew becomes a spontaneous stimulus. So next time I see a joke, my teeth automatically goes in. I don't have to think about chewing. but my teeth automatically goes in. That means the fifth cranial nerve connects across to the frontal cortex. That is the beauty of our brain. And lay the stimulus to the chew, the smile comes up spontaneously. And this is what could be done when a drop to sacrifice the nerve or to be going around the nerve. We are there to help you out. So that's what I'm trying to put out here, sir.
Absolutely. Point well taken. In fact, I remember this case as well. This too happens to be an international patient. This was referred by Kanu, who is here with us. And this was a case of a paraganglioma with the long-standing facial nerve paralysis. And we obviously removed the tumor, and then we kind of simultaneously did this. So you were doing the eyelid part, and then you came over to, I took a break, and then you came over to do the 5/7 anastomosis. So very interesting case, long surgery, but at the end of the day, it was a thriller, and we were all very happy with what we achieved. And if Kanu is here, I'm not very sure if the patient is. I saw him a year later because I had the good fortune to be invited for one of the congresses organized by the Bangladeshi ENT Society. So I saw this patient, and he was doing very well, you know. So, but to get to the finer details of his facial expressions and to evaluate the 5/7 anastomosis, I think you would be a better person. So I found that there was significant improvement in his facial function. The tumor obviously was gone, and I think if Kanu is there, he would be able to tell us, because he was the one who referred the patient, and the patient would be definitely going back to him for follow-ups.
Hi, Sam. Hello.
Yes, Kanu.
Hello.
Do you remember this patient?
I actually, yeah. I think he's fine. He's the Facebook friend of mine, and definitely you also.
Yes.
So most of the most of the time I see his update.
Okay.
Recently, I see him. He has joined in a company. So I think he's fine. He hasn't got any problem. And I see if he has got any problem, he will definitely contact with me or you, because both of us are easily accessible to him. So it is actually the excellent surgery. I can remember. Most of the time I just tell the history to my colleagues and seniors. Actually, it is nothing to say that what you have done actually is an excellent job. And we are actually, me and from Bangladesh, we are very grateful to you. Actually, you have done a tremendous job for us. Especially, you know, you have dealt many of my very difficult cases, and most of the patients are very, very happy. Thank you, Sam, for your outstanding job.
Thanks for your support. Thanks for your trusting me. And whenever you give me a call, I get scared, because some of the cases that are very challenging, as you said. Most of the cases you manage yourself, the ones to leave behind are really, really difficult cases. So it's always nice. It's always nice to you know, dwell on some of the cases that you referred. And yeah, hopefully all of them are doing well. A lot of them are directly in touch with me, and I'm sure a lot of them are in touch with you as well. So far it's been a good partnership. Thank you, Kanu.
Yeah, thank you, Sam.
Okay. So Vishwas, is there anything else you would like to touch upon? Again, you're muted, Vishwas. You need to open your microphone.
Yeah, thank you, Professor Kanu and the Bangladesh team, to send these patients all the way here. I mean, that's a great thing to motivate them to travel across in the city, but travel across countries is something that you're doing great. Thank you so much.
I want to just comment on for more minutes for Mr. Vishwas. Actually, the facial nerve palsy is one of the issues. Though nowadays it is decreasing day by day, but even then, in some advanced cases, we have to sacrifice. But we have no way to regain the function, or at least some sorts of aesthetic part of the facial nerve. But you are the guy who have done the outstanding job. I see many patients who are facing problems. So now we don't have any way where the patient will go, and the patient just lives with this sort of disfigurement and some sorts of, you know, it is one of the important depressive, emotional part of any patients, any human being. So I think I congratulate you. I'm amazed to see what you have done, and I think many of our patients will get the benefit from your very advanced and outstanding performance. Because just the last day, I visited one more patient. The patient had a facial palsy near about grade 3 after a road traffic accident. And one of my senior professors asked me to see the patient. So I am not very much expert of doing the facial nerve reconstruction, but even then, so as it is traumatic case, I assured them, let wait. If it is not, there are multiple fracture in the petrous bone, so I don't have any courage to handle this case. So I rather wait and see. If the patient needs some source of help, again, this patient will have to go to you. Definitely, it may be later. So I think what we have seen today, all the options are now available. It may be 1 year, 2 year, 3 year, 4 years. Because I am very much happy to see a patient has given you the consent after several times of operations by some renowned surgeons. Even then, so the confidence are being increasing day by day. Being a skull-based surgeon, my great friend, the Sampath, and definitely you too also, because this is indispensable part to regain the functional or some emotional aspects of facial. Thank you, Vishwas, for your very nice and excellent presentation.
Thank you, sir. That was very kind words. I hope to meet you soon after this corona pandemic and share more thoughts from you on how you going about it.
Eagerly waiting to see you too also.
Kanu is a great friend, and he's one of the keenest learners of the subject, I would say. So we kind of struck gold of a friendship in 𝐒𝐤𝐿 when he had come down to me, to visit Group Pathological, and we've gone a long way for several years now. And I see that Kanu is so is so engrossed in learning the subject, and always wants to push the boundaries, and he's an academician, writes papers, and ever since I stepped into Bangalore after coming down from 𝐒𝐤𝐿, my academic work has taken a little bit of a backseat because of the fact that there's so much of clinical work to do and we have to set up so many things. But Kanu is the one who constantly keeps goading me to write articles, write case reports, and he himself has written several articles which he has shown it to me, and so great partnering with you, Kanu. So I am sure we'll go several years like this. Thanks for joining in. And Vishwas, thanks again for your brilliant presentation. It's been great having you on the show. And for those of you who are still interested in a little bit of skull base, so we will show a few slides of what we did with the Petrous bone colostoma, because I think the audience is mesmerized by what Vishwas did. I think after a long time, I'm kind of being outshone in my own show, so to say. So, okay, right.
I think I've bored people for now 1.5 hours, so they don't have no space left.
No, absolutely no. One thing in our show is that there is no time limit, so we go on. It's our show. Who wants to stay with us stays. Others can leave, and we put this on YouTube, so there's always a chance to go back and see those portions that people have missed. So. We have time, all the time in the world. So for me, it was a great Friday. Otherwise I would have gone home and there's nothing else to do. It's a lockdown here for us. I'd have probably seen some sad Netflix movie. But it's been a refreshing evening learning facial plastic. Thanks, Vishwas. Thanks again, and we will go ahead with the rest of the presentation.
Thank you, sir. Thank you for the time and all the support in making this possible. I think ultimately it's our patient who consented to undergo this procedure, whom we need to be extremely grateful to. And thanks for all the attendees who are listening in today. And thanks, Ganga, for coordinating the show. Sir, with your permission, I have patients waiting. Can I take leave? And I'll be listening on the way. though I might not be able to speak.
Absolutely. Thanks, Vishwas, for your time. Go ahead and finish your consultation, and you'll be able to see what you would probably miss in the Facebook links that we'll provide in YouTube. So tomorrow, all this will be shared in YouTube, and you can always have a look at the rest of the presentation in case you happen to miss it. Thanks, Vishwas,
Yes.
and have a good evening. Thank you. Bye-bye.
Thank you, sir. Good night. Yeah, bye.
So we will now go to the surgical part of how we went ahead and removed the facial nerve, Petrous bone cholestoma. So if I may go back to the presentation. So this is where we stopped. Vishwas took over from somewhere from this point onwards. Yes, so I'll be taking you through the motions of what we did with the tumor that this patient presented to us with. So this is the patient. Now this slide shows that we use a facial nerve monitoring for all our patients. Facial nerve monitoring is an integral part of skull-base surgery, and I don't think any student of skull-base surgery should be even thinking of attempting any of the cases of skull-base surgery without a facial nerve monitor. Now, we not only have a facial nerve monitor at our disposal, we also have a neurophysiologist. Maheshwari and Richard are two of our neurophysiologists. Maheshwari assists me for a lot of my cases outside Manipal, and in Manipal I have Richard, both of whom are excellent neurophysicists, and they are with me from the incision. Even before the incision, they come in fact, before I start the case, and they set up the electrodes and they set up the system, and they stay with me right up to the fag end of the surgery. So the reason why I show this slide and I talk about this is because of the fact that when I was using the nerve monitoring system by myself, doing everything by my own, in the first, I would say, first 1 year of my, doing my surgeries in Bangalore, I realized that there were a lot of technicalities in the nerve monitoring system that were beyond my knowledge or my comprehension. So the basic things, and that was emphasized after I actually met Maheshwari and Richard, and all the things that they brought to my notice. I've been using the new nerve monitoring system for several years now, close to a decade, but the kind of information I got from the participation of the neurophysicists in my team has been tremendous. And I realized that I'm not going to do any more surgeries without these guys being around with me. And I got so much of additional real-time inputs during my surgery that I would probably, small things that only an expert can deal with. And those small manipulations and inputs made a huge difference in some of the in the results that I could provide with skull-base surgery. So so then we went ahead, we did a marking for the tumor excision. So we always go for a wide post-oral incision. In a translabyrinthine approach, this will be even wider. We go 2 finger breadths above the ear, 3 finger breadths behind, and 1 finger breadth below the ear up to the master tip. The lower end of the incision stops at the master tip. But in this case, we have a slightly more conservative, I would say, approach, because we are not going intradural or into the cerebellopontine angle, and also so because we have the Osia implant itself to place. So the Osia implant was designed to be placed. Now, coming on to the Osia implant, it's a brilliant implant, beautiful technology, piezoelectric technology, and Osia itself stands for Osseointegrated Steady State Implant. So that's what Osia stands for. OSI is what it is. So there are 2 components. One is the BI300 implant base, which is what has been used in Baha all along. And the other thing is the implant itself, which is called OSI 200. So we have a BI300 implant and the OSI 200 Osia implant. I'm going to talk about this as we come to the steps where we are implanting the actual Osia. So now the implant template led us to a marking like this. Now this had to be in a skin pocket. So that also kind of makes it a limitation to have a very wide post-oral incision. Of course, it can go posteriorly. There's no harm in it. But yes, it's always nice to have the processor closer to the ear rather than have it high up in the head. Now, the incisions described for Osia thus far in literature, and this is information from the company itself, from Cochlear from Australia, have always been a straight vertical incision with a hockey stick, reverse hockey stick posterior, I would say, an extension to be able to place the implant. So it was something like this, So that was a traditional implant, and most of the Osia implants that have been done in UK and USA, where it has been launched earlier, has been for microtia and for other mid-ear pathologies. But this is for the first time, as far as I know, in the whole of Asia Pacific region, because the launch was done for Asia Pacific in India on the 1st of April, that an Osia implant was placed for the first time simultaneously ipsilaterally with the complex skull-based pathology. We are the first center to do an Osia implant for a skull-based surgery, and the second Osia for all indications to put together, because there has been an Osia implanted just before we did for microtia of the ear. So now the challenges that come with Osia placement along with skull-based surgery is the incision itself. How do we make a skin pocket so high up, so posterior, along with the existing skin incision? I was advised, we had a training module a couple of days before the surgery, where we tried this on a model, and we found it quite difficult to make a skin pouch in this region because it was far and deep and posterior. So then in that model, I took a posterior limb to this incision and then used the flap elevation to place the implant. But at this point, I was still not very happy with using a posterior incision so far posterior. Now, an incision, a posterior limb to a vertical incision close to the ear doesn't take you anywhere near the suboccipital areas. But a posterior limb to this particular postoral incision, which is wide, which is a wide postoral incision, would take you to the suboccipital areas, which means that we'll have to probably section some of the insertions of the suboccipital muscles, which I was in no mood to do. So in the beginning, I put this, I marked the implant out, and I hoped and prayed that I would be able to somehow retract the skin and find a pocket like how we do in cochlear implants, and get a nice snug pocket to push the Osia implant in. So this was, and then we obviously had to keep a 1.5 to 2 centimeter distance from the side of the implant, so that the implant is away from the incision site. The BI300 implant site had to be marked with methylene blue, and then we went ahead to do the surgery. We always use a craniotomy tray for all our surgeries, and then we used a wide postoral incision. You see skin flaps being elevated here. A T-shaped skin flap is being elevated. So in the first flap, we take the flap in the subcutaneous plane. The second flap, we always take it in the musculo-periosteal layer. So the whole muscle with the periosteum comes out. Why is it so blurred? Okay, so anyway, so a couple of these pictures are blurred. I am not sure why. These were fairly robust pictures. Anyway, so I don't know if it's on my screen or if it's everywhere that's a little more blurred than what it, it's not so clear as what it should be. In any case, how is it in your screen, Ganga? Pretty clear, isn't it? So in the other screen, it looks okay. I don't know how it appears to you. Okay, so now I usually take a T-flap and I leave this posterior attachment intact, and we go ahead and do our petrosectomies in this area. Now in this case, because I had to get to this region and I couldn't get it with this flap around, I made a posterior incision, took the whole flap down to expose the bone. Okay, so here you see, these are good pictures. So now you see, this is the now a posteriorly based flap became a inferiorly based flap like this. Okay, so it became a inferiorly based flap like this. Now, this was a preparation done for Osia. Osia was the last step of the surgery. So we went ahead to do a blind side closure. We cut the skin, the external aortic canal skin, inverted it inside out, put sutures, and we did a blind side closure. Now, I'll briefly take you through the surgical picture so you get a fair idea of what we did, and then I'll take you through the surgical video. So if you see here a little bit of disease right up in the cortex, but not too much here in the cortex. You see that the cortex has not been drilled out, so nothing much has been done even as far as mastectomy is concerned in the previous surgery. So we got a fairly virgin mastoid, and then we did a mastectomy. The reason why I keep the posterior canal wall intact is first to ascertain the anatomy, especially in case of previous surgery. So the more we have landmarks, the more we have bone, we are always we are always sure about the anatomy. For me, the bone is the principal navigator in lateral skull base surgery, more than the neuronavigation machines. So where there is bone, I know where my landmark is. It's like the path forward for me. Okay, so I keep the posterior canal wall in the beginning. Just try to ascertain what was done in the previous surgery. Nothing much. All this was done by me. So we drilled out the whole, or maybe Ganga. So she was the one who started the surgery. So we drilled out the mastoid, thinning out the posterior canal wall. Sigmoid sinus has been isolated. Facial nerve is more or less delineated, and then we bring the canal wall down. Okay. So then we bring the canal wall down. We see the facial nerve absolutely intact. So so the facial nerve decompression surgery that was claimed earlier, I'm not sure to what extent the decompression was done, but yes, so this is what we achieved with the canal wall down. Nicely skeletonized the facial nerve from the geniculate ganglion all the way. Now, if you see here, this has been a 10-year history of facial nerve paralysis. Okay, plurioperated case. Now, after a 10-year history of paralysis, you see the status of the facial nerve. The facial nerve is very much intact. The disease is nowhere to be seen, because the disease is in the Petrous bone. That's why this is a Petrous bone cholestoma. You're not going to find disease like in mastoid cholestoma. As soon as you drill out, you find white matrix and you right. No, this is much deeper down in the skull base. So if you look at this facial nerve, it's practically intact, practically virgin again. And now as we go in, as we drill out more of the tympanic bone, we begin to see some amount of disease medial to the cochlea, right next to the carotid, in the area of the carotid. Nothing here. No disease in the mastoid, no disease in the epitympanum, facial nerve intact. And here you see a total decompression of the facial nerve has been achieved from the geniculate ganglion right up to the mastoid segment. And here in this case, we have drilled out the cochlea, and then you start beginning to see the facial nerve. Again, here the labyrinthectomy has been done. The reason why a labyrinthectomy has been done is because we need to reach the internal artery meatus, isn't it? So we have seen in the scans that the disease is medial to the internal artery meatus, not lateral. So we don't see, but this is a labyrinthectomy just to get space under the facial nerve, to be able to use that additional space under the nerve to get into the more deeper areas of the Petrous apex. Here you see that the jugular bulb is already visible. Facial nerve is completely delineated from the geniculate ganglion. 10-year-old facial nerve paralysis, the nerve is intact. Now, does that mean, now we have seen the electrophysiological tests as far as the facial nerve is concerned, ENG, EMG. We have seen that there was practically no response, 2 millivolts on the opposite side and practically 0.2 millivolts on the ipsilateral side, meant that there was practically negligible. But you see the anatomical integrity. I was fascinated to see the anatomical integrity of a facial nerve with grade 6 facial nerve paralysis. 10 years later, the nerve looks okay. Now, what did we do? Now, these pictures obviously show the cholestoma removal. But staying on the topic of the facial nerve, we did a nerve monitoring. We used a facial nerve stimulator to test this nerve intraoperatively, because if the nerve was functioning in whichever possible way, I still wanted to preserve the nerve, and I was hoping that in some which way the pressure on the facial nerve would release the and somehow the facial nerve activity would come back, and hoping against hope 10 years later we would be able to somehow. But unfortunately, when we did the facial nerve stimulation at, we begin with 0.5, there was no response at 0.5. At 1 there was no response, 2, 3, 4, 5. And I knew that it was a hopeless scenario, but just to, just out of curiosity, we tried it at 10, and there was no response at 10. We tried it at 20 milliamps, and there was no response to the facial nerve stimulation. So that led us to believe that though the anatomical integrity of the facial nerve has been preserved, it was a dead nerve and nothing useful would come out of it. So we section the nerve to be able to get a better access. And then we see that the whole of colostoma is now being exposed. You see now we are medial to the internal aortic meatus. Where is the internal aortic meatus? The facial nerve is going down here. So this is the area of the internal aortic meatus. The whole lesion is medial to this. This is the anterior wall of the internal aortic meatus. Now we are in the petrous bone, more towards the petrous apex. More and more colostoma comes out. It's not as small as we remove large tumors of the petrous apex. So for me, it was a smallish lesion, but going inside, we had a significant amount of disease. Here you see the entire carotid exposed and the matrix on the carotid. We have drilled the tympanic bone entirely. There's no tympanic bone. This is the temporomandibular joint. The parotid is here. The jugular pulp is here. The stump of the facial nerve is here. And this is the whole carotid being exposed. Now you see we have cleaned the carotid of the matrix. More and more matrix comes into the picture, and we keep removing it. The cochlea has been drilled out. This is bone on the posterior fossa, the posterior petrous face on the dura or the posterior fossa, and that's after completion of colostoma excision. And this is that small piece of bone Ganga pointed out. In fact, we made it a point to point out that bone because I wanted to show what is the medial limit. The medial limit is clear bone, and that was that small piece of bone right up to at the petrous apex, separating the petrous bone from the sphenoid sinus. So if I go medially here, I would get into the anteromedially, I would get into the sphenoid sinus, and if I go inferiorly, I would probably get into the clivus areas. So this is total excision of the tumor. The carotid is completely bare. This is the vertical portion, geno, horizontal portion, more towards the lateral portion of the carotid. All this is completely bare, and we had to obviously take a lot of care to make sure the carotid did not get injured. So this is petrous apex, the last piece of bone in the petrous apex, and this is the carotid. This is the jugular bulb, facial nerve cut. This is the labyrinthectomy done. Internal aortic meatus is here, and complete total tumor excision has been achieved. Now we go in for Baha. Steps of Baha. First is to put the template, then to make a hole for the BI300 implant, and then we use what is called a bone bed indicator. Now this is some of these terminologies are new to me, so I need to refer. So this is a bone bed indicator. This I'll show this in the videos. The bone bed indicator is something that is used to rotate to make sure that the bone is flat, and the Osia OSI 200 implant is on the BI300 implant, which means that it is not supposed to touch any other bony surfaces, because if it touches any other bony surfaces ahead of its contact with the BI300 implant, the transmission of the vibrations will get distributed between the implant and the other bony surfaces. So we have to make sure that the Osia implant fits onto the BI300 implant devoid of any contact with surrounding bone. So that's the reason why we have this. So this is turned 360 degrees to make sure that there is no contact. I'll show all this in a video to be able to explain this better. And then we went ahead and placed the BI300 as it is done in all Baha surgeries. So that's the BI300 implant. That's the Osia implant, fresh and new, shipped directly from Australia. One of the first three implants brought into India and shipped into India. So so this was so here we have the transducer, and we have this whole implant is based on piezoelectric technology. So that's the big jump in technology vis-a-vis Baha, which is based out of an electromagnetic technology. So here we have a piezo-powered implant, and we have a magnetic coil here. So this is the magnetic coil, and this is the transducer. So the difference between Baha and Osia is that the transducer component, which was electromagnetic, was in the external component, along with the processor. Now that whole thing has been shifted inside. So here you see the transducer, and that will impinge and get screwed up onto the BI300, which will then get also integrated. So this is the magnetic coil, and the magnet then communicates with the external component. So the external component has only battery, magnet, and the processor. So it doesn't have the transducer. The transducer has gone under the skin, and that's the big difference. The second big difference, apart from the piezoelectric technology or piezo power technology in a Osia implant. So this is the Osia implant. I'm picking up the implant and screwing the implant. Of course, the pocket has been done, and we're screwing the Osia OSI 200 implant on the BI 300 implant that is used in all BAHA surgeries. And then we tighten the screw using the same set of instruments that is used in BAHA. And that's so you see, somehow we could manage by retraction and Ganga's strength, I would say, all using all her strength, we could probably we got away without having to make a posterior limb and take the skin flap up. So we were able to place the implant in the same incision, which is brilliant, because then we have a nice pocket, and we don't have any laxity as far as placement of the electrode implant is concerned. So then we place fat and we close the cavity. The skin is closed in. There was CSF leak because we opened the internal meatus. Whenever there's a CSF leak, we have to make sure that there is an absolute watertight closure. So this is all Ganga's work. Beautiful closure, beautiful fat placement, and so all this has come out very well. And we happen to take out the sutures recently, and the patient is doing very well. He is healing very well. Everything, the facial plastic work has come out very well, and the patient is very, very satisfied. Just unfortunate that the father of the patient contracted COVID, and they have to be in isolation for some time. But otherwise, the patient himself, the boy himself, is doing extremely well. Now, with these slides, I will move to videos. So I'll have to close this. I'll stop sharing this presentation and then move on to sharing my screen to okay. So here it is. So I'm going to go. So these are raw files. We have not edited. Been very lazy ever since I came down to India. I've edited very few of my over 200 plus, close to 250 plus, I would say, such skull-based surgeries. Now with Ganga around, I guess we'll get a few more videos edited. But I'm going to take you through through some of these videos. So I'm going to open up one video at a time. And now I have to share this video like this. Okay, and there we go. So is it okay? Is it coming nicely? Okay. So we're at the beginning of the surgery. We are cleaning the ear. I'll just quickly run through this. This is how I'm going to show, and this is how I've done my case of the months in the past as well. So let's, so that was just to show the lesion and the tympanic membrane. So those pictures have been shown earlier. So the first step is to section the internal external auditory canal. So in this case, we have cut the external auditory canal. Master tip is completely exposed. As I told you, we have a flap which is inferiorly based this time, and you see that very little, a small, I don't know, a small mastodectomy cavity is there, but practically not much of one has been drilled out. Here you can see that I've sectioned the external auditory canal. The skin can be seen here, and you're able to see the other part of the more medial part of the external auditory canal. So hemostasis is achieved, and now I start cutting the skin away from the cartilage. Okay, so this is done. Again, there are small, minute details in this. I don't really want to be going into the detail of this because we've already had a long lecture so far, and for the want of time, I would like to cut it. But yes, I've made these points amply clear in some of my earlier presentation. So we use fine, sharp scissor, parotoidectomy scissor, and we slowly start separating the skin. Okay, with absolute hemostasis. That's vital. I don't want a drop of blood during my blind side closures, because we have to ensure that the skin that is being separated from the cartilage doesn't get punctured. So you see, I use skin hooks to retract, and I gently separate the skin with my tip pointed upwards. You see how I'm using my scissor tip pointed upwards, and making sure that I don't puncture the skin of the external ear canal, because if the skin is punctured, then it's difficult to close it. And if it is even worse, if it goes unnoticed, it's going to lead to a new Petrous bone cholestoma. Okay, so here you see I have separated. Now the cartilage is coming into view here. You see here, this is the cartilage that's coming into view. And okay, so I go to the next video. Okay, in this video, you see the continuation of the blind sac closure. Okay, now we begin to see the cartilage there. So I'm separating the canal from the cartilage. Sometimes the cartilage can be, what do you say, split into two. So, so here you can see that the cartilage is clearly seen. I prefer absolute hemostasis. Now you can very clearly see the cartilage, and the skin is separated from the cartilage all around. Very important that as you go deeper, you don't puncture the skin, because that's where visualization becomes a little difficult. So that's the point where one needs to be very careful. So once the external aortic canal, you see all four directions, I have had a nice release posteriorly, and that's anteriorly, inferiorly, that's inferiorly, this is superior. I'm holding the posterior edge, and anteriorly too, I've had a fairly nice wide release of the canal wall skin. Now I bring it up on the other side. I bring it up on the other side, inside out, and then I suture the two edges. I suture the two edges, which ends up looking something like this. Okay, so you see all around I have healthy skin, which means that let me go back a little bit. That's important for you to see that all around I have healthy skin, which means that there are no puncture superiorly, posteriorly, anteriorly, inferiorly. So this is a perfect blind sac closure. I then begin the second layer. So the second layer involves suturing the cartilage. Now you see I have elevated the cartilage from the parotid, and I am now reinforcing the first layer of blind sac by suturing of the cartilage like this. So now the whole first layer is buried within this the two cartilage edges, and we have a watertight blind sac closure. Okay, so you see at the end of the day, this is how it looks. Okay, even that amount of blood is unacceptable. I would like it absolutely bloodless. You see that the cartilage has been closed over the first layer to be given a perfect two-layer blind sac closure technique. So this is about blind sac closure. Okay, now we collect periosteum to make sure that we have something to close the eustachian tube, which is going to be opened up during the drilling. So we harvest periosteum, and that is used for closure of the eustachian tube, and also could be used to seal the internal aortic meatus, or worse still, sometimes if there is a rupture of the carotid or puncture of the carotid. Rupture should never happen. Punctures, can happen, and if that happens, you need to make sure there is something around. You can use periosteum or even muscle to close the parotid. So this is how we harvest periosteum. Now I go to the next video, that is that shows drilling. Can you see the video? No. Okay, so that's something that we have to do every now and then. Okay, so now you see the cortex of the mastoid. So we start drilling. Ganga is on to the job. She's doing a fabulous job, doing a mastoidectomy, and that's a little bit of, I don't know, something, it could be something from this previous surgery, or But that was how much, if it was from the previous surgery, that was how much of the mastoid that was exposed in the previous surgery. So now you see that we have done we're doing a mastoidectomy. So there is a lot of mastoid left unexplored, and nice wide mastoidectomy is very important, because I always say in all my skull base lectures, the deeper you want to go, the wider should be your mastoidectomy. If you want to go deep, have a wide margin, because in a small narrow cavity you will never be able to go into the deeper aspects of the skull base. So that's how it is. So we have achieved a yeah, so so this is the antrum area. So this was the corner septum which was drilled out. So the sigmoid is coming into view. Okay, so we go to the next video. Let's go to video number 5. Share screen, video number 5. Yes, I have to do this. So this is the sad part. If you don't edit video, we have to go like this in a very labored way. So this is the next video. So here you've seen that we have done a fairly nice cortical mastoidectomy. We are achieving hemostasis with a large fine diamond burr. As I told you, the posterior canal wall has been maintained to understand the anatomy, especially when there have been multiple cases, surgical procedures done in the past. I prefer to have as many landmarks as possible. So here you see that thing is a defect in the posterior canal wall. So this is the posterior canal wall. There is a defect in the posterior canal wall. Antrum is intact, but there is disease beginning to appear at this point of time. The cortex is completely free. Now we go drill.
Just check if they're able to hear your voice. Somebody messaged that they're not able to hear. Others.
No, I'm. Hello, am I audible? Hello, am I audible? Can somebody tell me if I'm audible?
Yes, yes.
Okay, perfect.
You are, yeah.
Good. Okay. So now we go ahead with the mastoidectomy. And now I'm bringing down the posterior canal wall. It took a while just to understand what was done in the previous surgeries. Nothing much. So nothing much to amuse me, at least. And then so yeah, so there you see that I'm drilling the anterior canal wall, which is predominantly the tympanic bone and its insertion to the squamous portion of the temporal bone. And then that's drilling over the root of the zygoma. Far anterior epitympanotomy is being done, and there you can see that the medial part of the canal skin is coming into view. Basic steps of mastoidectomy. Constant irrigation is done, and then I bring down the canal wall. So here you see that I use a high-speed cutting burr. We use the BNR drill system in almost all the centers that I operate. I operate predominantly in 2 centers, and in both places we have a state-of-the-art 80,000 RPM BNR drilling system. It's my all-time favorite. And you see that now I'm drilling on the facial nerve, jugular bulbaria, tympanic bone. So see, at no point of time does my drill slow down. You know, my control would and the pressure of the drill over various structures differs, but there's no real point. When I press my leg onto the drill pedal, it is always full throttle. So there's no real logic in reducing the drill and appearing to be in control. That it's actually a false sense of security that you get by appearing to be in control. It's not really control that you have. It's just a false sense of security. I drill at the highest speed, but what the control lies in your hands, in your fingers, and how you hold the drill and how you implement the drill, and the pressure that you apply over various structures. So here you see a very looks good. For those who are uninitiated into skull-base surgeries, could look like aggressive drilling of the facial nerve, but trust me, I know exactly where the facial nerve is. So going forward, it's a little bit of a bleedy mastoid, I would say, probably because of the previous surgeries and new bone formation. So here you see that I'm trying to identify some soft tissue, as just trying to figure out if that's some part of the facial nerve that's dehiscent or whatever, but no, that's not a dehiscent nerve. And then I go ahead and, so let's finish this part. I have now come to a situation where I have nicely delineated the facial nerve. At this point of time, I would always like to emphasize again and again the fact that when you see the lateral canal and when you see the posterior canal, I always emphasize on what I call the facial dimple. Now there is this lateral canal, the posterior canal is here. Around this point is where you can actually safely drill, because there is a deep pocket of bone which is neither that of the canal nor of the posterior canal, and you can drill bone there without damaging the both the canals. And right in front of that, that facial dimple, as I call it, is the facial nerve. So for me, the facial dimple, more than anything else, leads to the facial nerve in all my cochlear implants or otological or my skull-based surgeries, because that's the point of action as far as facial nerve is concerned. The other landmarks, digastric ridge, doesn't really is not really the point of action as far as the facial nerve is concerned, nor is the incus. The incus goes off, so incus pointer for me is nothing. The lateral semicircular canal, again, and the facial nerve is medial to the lateral semicircular canal, so this again is not very useful for me. But the fact that there is what is called the facial dimple, again, it's a terminology called by me, and I look for it at the junction between the lateral canal, posterior canal, and just anterior to that would be the facial nerve. And I never see us fail in identifying the facial nerve when it comes to using the facial dimple. So now let me go ahead and let me see what I have here in movie number 7. I'm going to share that with you in a while. Share screen, go there, share. And can you see now? Yes. So now you're seeing me drill in the more medial aspects of the middle ear. You've seen that I have delineated the facial nerve entirely. The Petrous apex colostoma is coming into view. The Petrous bone colostoma. You see the colostoma there. You see this colostoma there. You see the colostoma there. All medial to the internal auditory meatus, and that's coming into view as we go ahead and drill the facial the mastoid. Okay, so if you want to see some drilling, I can show. So now again, if you look at this stage, let me go a little backward. So here you see that the facial nerve from the geniculate ganglion right up to the mastoid segment is completely delineated. Footplate of the stapes is preserved. Round window is here. The cochlea is here, and medial to the cochlea is all colostoma, nothing but colostoma. So if I have to go reach medial to the cochlea, I cannot preserve the cochlea. That's why this is a transcochlear approach. And in transcochlear approach, typically we also end up rerouting or transecting the facial nerve. So now I'm drilling the last remnants of the tympanic bone medial to the temporomandibular joint, which is here. So at this point, I'm on the bone over the internal carotid artery. So at this point, somewhere down here, yes. So this is the jugular bulb. I'm medial to the jugular bulb. I'm drilling out the cochlea, kind of decorticating it at this point of time and going forward. So that's the facial nerve. The entire nerve is delineated. The whole thing is colostoma. This whole thing is colostoma. Facial, the carotid would be somewhere at that point, just where the bleeding is occurring. Okay, so that's how we control bleeding everywhere whenever we are drilling. So using the fine diamond burr, I also use a coarse diamond burr to good effect in a lot of places. That is very, very useful. The labyrinthine block is preserved, as you see here. The labyrinthine block is preserved. This is the jugular bulb. Medial to the jugular bulb is a carotid. And now I'm testing. I guess I'm testing the nerve. Let me see. And this is what I told you. So I'm testing the nerve because the nerve is exposed, more or less. So at this point, we saw that there was practically no response, even at 10 or as you see that part of the nerve is exposed, and despite the fact that it's exposed and we're giving very high stimulation, 10 or even 20 milliamperes, we could not get any response from the nerve, which means that it was a dead facial nerve, practically useless for all practical purposes. Nevertheless, I had the intention of saving the nerve if it did not impede my access or visualization of the disease per se. So now I am on the this thing, cochlea. See, whenever there's a lesion between the cochlea and the carotid is pushed medially or anteriorly. So in this case, I know I've studied my scans and I know my carotid is somewhere here. So there is this expansor lesion has increased the space between the cochlea. Otherwise, right next to the cochlea would be the carotid, right? We also, you see the pulsation there? That's pulsations of the carotid, okay? So, and whenever you're coagulating on the dura, you'll always have to make sure that the dura, that you irrigate the dura, okay, in order to not to damage the dura or the vessels beneath the dura. So, so now I'm using a coarse diamond burr, if you've noticed, and I'm drilling out the cochlea. I'm on the jugular bulb. I'm fast, but I know how much pressure I'm applying. So for those of you who think this is aggressive, please don't think so, because you know, if you see how we go about doing our surgeries, you'll realize that it's absolutely safe, and in fact the only difference is speed. Now yes, I have to share. This is the next video. We are now drilling the cochlea out. Cochlea is being drilled out. I'm not scared of the carotid because I know the carotid is a little more anterior than what it should be. Now when you drill out the cochlea, you obviously get to the modulus. When you drill out the modulus, you get into the point where there is a CSF leak, and I guess it's about to happen now if it's not already happened. So again, creating space, drilling out that extra little bit of bone medial to the jugular bulb to be able to see the petrous apex. Every millimeter of bone drilled out is important for deep visualization of the petrous apex. So now you see the whole lesion coming into view. The cochlea is drilled out completely. There is, I'm sure, a little bit of CSF. If I can just, yeah. So you see that CSF leak. You see that that is because of following the cochlea up to the modulus. Now I'm going ahead. Doing a labyrinthectomy. Let me go a little posterior. So I'm doing a labyrinthectomy now, drilling out the lateral canal, posterior canal, and the superior canal. So this is the superior canal here. This is the ampler end of the lateral canal. This is the non-ampler end of the lateral. This is the ampler end of the posterior. Superior canal is all drilled out. I did a complete labyrinthectomy. The reason why I'm doing a labyrinthectomy is because of, so there's a small bleeder on the facial nerve area. Anyway, let's go ahead. I control that bleeder, and now I finished the labyrinthectomy. Total labyrinthectomy is achieved. I wanted to inspect this area to see if there's any lesion medial to the internal aortic canal, lateral to the internal aortic canal. There was nothing lateral. So all these areas, this area, retrofacial in the deeper, in the more inferior portions, all were free of disease. So everything that was present was all medial to the internal aortic meatus. And I also made preparations for a posterior translocation of the facial nerve to be able for me to be able to go into the more deeper aspects of the petrous apex. So I'm drilling out everything just for better access and for me to be able to do a posterior translocation. That was in my mind before, but then after we did the facial nerve stimulation test, I realized that there was no real point in preserving this facial nerve. So then I went ahead and sacrificed the facial nerve, because you see, I had made all arrangements. So this is a classic transaortic approach. Till now, it is a transaortic approach because the facial nerve is still in its fallopian canal and all the bone around it has been removed. The moment I either translocate it or cut it, as I did it in this case, it becomes a transcochlear approach when we go through the facial nerve, through the cochlea, and go into the more deeper aspects of the facial nerve. So you see, again, everything removed. CSF leak is clearly seen. This is the cochlear nerve getting into the internal aortic meatus. The cochlear nerve will go like this and come into the internal aortic meatus. The facial nerve is going here. So this is dura. Again, you see CSF leak happening. I'm drilling out all the petrous bone. Okay, I'm drilling out all the petrous bone. The whole of the cholestoma matrix can be seen here, medial to the drilled out cochlea. Now, this is all petrous apex bone. Okay, now this is not cochlea anymore. This is all medial to the cochlea. I'm drilling now medial to the jugular bulb. Okay, the jugular bulb is lateral. Now my drill tip is medial to the jugular bulb. Around the entry of the cochlear nerve into the internal aortic meatus. It's already the internal aortic meatus, and you can see that I am drilling. Don't worry, that was not a puncture. That was just some granulation tissue medial to the carotid. See, one thing is, you need to be very thorough about your anatomy. You should know where your structures are. So if I thought this was a puncture of the jugular bulb or of the carotid, I wouldn't be aggressively using the bipolar like this. So here you see I'm bipolaring it because I'm 200% sure that some granulation tissue over or some scar tissue in the area of the colostoma. So you see that's settled it, bleeding controlled, and then we go ahead and I'm drilling all of the bone now. Whatever is there between me and the colostoma, the bone that is there is being completely drilled out. So that's the facial nerve standing in the middle. I gave it a good thought. I said, okay, the nerve looks intact anatomically. Electrophysiologically, 10-year-old facial paralysis. Electrophysiologically, clinically grade 6 facial nerve paralysis. 2 facial nerve procedures done. Facial nerve stimulator shows no response even at 20 milliamperes. So I decided to then go ahead and sacrifice this nerve, even if I did it with a heavy heart, because it really didn't make sense for me to. If there was at all some amount of response, even at 5, 7, I've got responses at 5, 7, 8. I've got responses at 8 milliamperes, but when there was nothing at 20, I realized that there was no way this nerve is going to be of any help being left alone like this. We were only complicating our surgery and nothing else. And there was because if I decide to sacrifice the nerve, I get so much more space, and for me it's a cakewalk, so but I made all arrangements. I tried my level best. Eventually the facial nerve stimulation was disheartening, and that was when I decided to go ahead and cut the nerve, sacrifice the nerve. So I'm going into 009. Okay, I'm going to share this video now. So I guess at this point I decide to sacrifice the nerve because we stimulated the nerve enough. Carotid is completely bare. Carotid is bare. Cochlear drilled out. All colostoma here. Jugular bulb is here. Tympanic bone completely drilled out. Bone over the cochlear carotid canal completely drilled out. So I'm now still delineating the internal artery meatus, and at somehow around this point I realized that it's worthless to say the nerve, because when I started dissecting out the labyrinthine segment, that is when I realized that the nerve was very thin, and that is where the compression would have occurred, and that is where the nerve is dead, and there was no hope for the nerve. So then you see there the labyrinthine segment, that is geniculate ganglion, and as I went forward, now you see the nerve is still okay, the nerve is still preserved anatomically, and then when I tried to look for the labyrinthine segment, there was a very, very thin nerve which was practically looking worthless. So somewhere at that point I decided to cut the nerve, and that's where the matrix also was beginning to impinge on the facial nerve. And if I would have left the nerve, I would have probably left a little bit of matrix as well. And it made no sense doing this on a 10-year-old facial paralysis with grade 6, where the facial nerve stimulation was absent even at 20 milliamperes. Okay, so anyway, so we'll go ahead, and the bottom line is I tried to preserve, but when there was no stimulation, I decided to cut the nerve. Okay, so now we come to matrix removal. You can see the dura exposed nicely here. I'm separating the matrix from the dura using a cotton ball. It's always important to realize and understand that the colostomas, big ones especially, should be removed with the matrix, and it's very important to not to debulk, and then finally leave the matrix on all these important structures, dural structures and carotid and all that, where it becomes difficult. So the more there is mass, the more it's easier for us to pull it down and apply traction. If you debulk it completely right in the beginning, then see, now I cut the facial nerve completely because the labyrinthine section, see, the labyrinthine is practically non-existent. You see, that's the labyrinthine segment. Labyrinthine segment is so thin, you see, nothing there. So that is where the facial nerve had, so that's the labyrinthine segment. So nothing there. So it was a very, very thin facial nerve with the pressure point being the labyrinthine segment of the internal artery meatus. So now with the facial nerve out of the way, I have the license to rip through the cholesteatoma. So here I am. going, drilling through the cholesteatoma, drilling out more bone. So again, this is the internal auditory meatus here. This whole thing is the internal auditory meatus. I am drilling out bone, and drilling out bone gives us exposure as well as security that you have not left behind any lesion behind. So I am drilling out all the bone now around the internal auditory meatus. This is transcochlear. At this point of time, it is a transcochlear approach because we have cut the facial nerve, we have cut the cochlea, and we have like a highway right up to the Petrous apex. So transcochlear approaches are fairly broad approaches, and there are again 4 types A, B, C, D, and you can add as we are doing here now. Type A is when you go around the carotid. Type B is when you go superiorly. Type C is when you're doing the infratemporal fossa. Type A extension. Type D is when you're doing a suboccipital approach. So all these are extensions to this traditional transcochlear pathway. So this is the traditional transcochlear pathway. If you go around the carotid 360 degree, now you can see the carotid pulsation. You see this pulsation here. So nicely you can see the carotid pulsation, you know. So we have, to an extent, I would say, delineated the carotid by around, I would say 270 degree. And the scan also showed that there was no lesion anterior to the carotid, so we didn't have to drill out any bone anterior to carotid. But yes, we followed the lesion as and when necessary. So this is the part of the lesion that's coming out medial to the internal auditory meatus. And we have identified the internal auditory meatus, and that's the dura of the internal auditory meatus and the middle fossa dura, all nicely seen. And I always use a cotton ball, try to remove the matrix. See, at this point, it's very important for us not to be in a hurry to debulk, because that will lead to some amount of matrix hidden somewhere. So take it in toto, slowly. See, when you do this, when you're using the cotton ball, apply traction. I could easily suck out half the cholestoma inside this and you know, feel good about it. But that's not what's important. What's important is you need that mass to apply traction. And by applying traction, you get the whole thing out. You're sure that you're removing the whole disease, especially in those hidden areas. You see, in those areas, it's important to run the cotton ball nicely and make sure every bit of cholestoma is removed. So we go ahead, separating, and wherever you have removed, you coagulate. Coagulate the dura, coagulate anything that is other than bone. So you see how I'm trying to squeeze out every bit. I don't want to leave anything behind. See, every bit with the cotton ball, with various degrees of manipulation using the cotton ball, I take out the entire cholestoma matrix. You see, bone, bare dura, bare bone. I'm pretty sure that there is no cholestoma. Now, if I had debulked, parts of the matrix would have stuck, and then I had to pluck out it in a piecemeal fashion, which and all these flakes. The worst thing is to take out cholestoma flakes. That's really, really difficult. Leaving behind some of those flakes would mean that you're ending up with a recurrence, you know, after a few years. So that's how we remove. You see how I gently peel. Again, I take the cotton ball, with the cotton ball, I peel, I make sure every millimeter of the cholestoma is removed. Now we are getting into more deeper areas. So I always leave behind part of the cholestoma on the carotid to the last. Two things, if it's not involved in the carotid, the facial nerve always comes at the end of my surgery, because I want to make sure that I give my full concentration, and I want to deal with the most difficult part later. So with the fish, similar thing with the carotid. So I don't want to have a carotid rupture in the beginning and then stop my surgery right in the beginning, isn't it? So I want to give the patient a good chance. So I do everything, and the last part is on the carotid. Some may argue saying that you're coming to the most important part at the fag end of the surgery where you're tired, but tiredness is in the mind of a surgeon. You know, when I am on this case, I don't know how the time passes. I mean, it's like seeing a brilliant Hollywood movie, you know. So the tiredness sets in after you finish the case. So it's really not tiring if you're fully focused. And in a case like this, you never know, you know, that you're tired. So that's something that I don't agree with. So dealing with the carotid at the end of the surgery is definitely possible if you're focused and if you love what you're doing. So now we are coming to the part on the carotid. So I did a little bit of debulking now, because I've separated a lot of it, and all this is all cholestoma, you know, just hanging in thin air. So we debulked all of that. So more cotton balls, more debulking of the lower parts, you see. Big cotton ball, carefully making sure everything comes out by traction without leaving behind any part. We go now. I would like to show you something on the carotid. Now this is using the cotton ball on the carotid. You see the matrix is being peeled off the carotid. I'm using a sharpish instrument, but that's because I have control. You see, I'm separating. It's a sickle knife, and I'm separating the matrix from the carotid now. That's bare carotid. That's carotid without the adventitia, without the carotid sheath that you see down in the neck. So here you have practically only the media and the intima. So it's a fairly dangerously thin carotid, and you need to make sure that you deal with it with caution and respect the carotid, respect the anatomy, and have a thorough knowledge of the anatomy. So that's how you deal with these structures. The structures will respect the fellow who knows the anatomy. So that's the bottom line. You should know your anatomy. That's the carotid canal, entry of the carotid canal. That's the genu. So now you are peeling the carotid, the colostoma from the genu, and that's, so you see how I'm making sure that every bit of matrix from the carotid is removed. So this is a very important step. I'll let it run for a while to show the entire, what I would say, cleaning of the carotid. Okay, so this is all medial to the carotid. Now we are medial to the carotid, and that's, that's the undersurface of the carotid, I would say. So that's the more horizontal portions of the carotid. Now we have crossed the genu, that's the horizontal portion of the carotid, going all the way up to the lateral portion. So carefully peel, 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 expose all area. Now you're able to do this only because you have a nice exposure. So your drilling also stops where the colostoma stops. So if you were in a hole, if your exposure was narrow, if you were dealing in a tunnel, you would never be able to do this confidently. You see, that was the upper limit of the colostoma, isn't it? So this was the upper limit of colostoma, and my drilling is adequate, my exposure is high, and if you're able to see it, that means the exposure was good. And the exposure was good because we planned it that way. We gave a wide exposure using the so-called transcochlear petrosectomy approach. So that's the upper limit of colostoma. We have removed everything out. So the carotid is more or less clean. So this is the bone, the Petrous bone, the last portion. I'm going to drill out more. Now I need to work on the undersurface of the carotid a little more. And you see, the fortune favors the brave, and that's something I've seen in all my surgeries, So if you are good, if you have done the right things, if you plan things well, you will have a point where you say, where what you think is would be the most difficult part, or what you think would be the difficult aspects during surgery, will somehow turn out to be not so difficult, and fortune would favor you. So at this stage, you saw carotid. I was thinking, okay, carotid, what? Now you see, it came out nicely. The carotid is completely, I've shown you all that I did. I didn't run through this video now. So I showed you carotid cleansing, I would say, right from from the beginning till the end. And it took me how many minutes? 7 minutes, I would say. And you see the carotid pulsating, and this is all you have to do, So again, go down into those areas. Hidden areas are the most important. And Ganga would know that we spend a lot of time after removing all this, inspecting the hidden areas, making sure that every bit of colostoma is removed. And you see, it comes out nicely. Again, use a cotton ball. Do not rush to suck out things, because the moment you suck out, you leave behind some disease. So yes, so now you see, I think there'll be a little bit of more of drilling to be done here. Once we drill, then only we are able to see the lower portions, and then we remove the last bit of now here posteriorly it's all dura. Okay, so there is no bone, dura is exposed, all on the dura, and we have to then remove the last portion. So this, for me, in this case, the carotid was not the most difficult part, but this extension into the infratemporal fossa here was a little challenging, because it was on soft tissue, infratemporal fossa soft tissue. That part you see here. Now this is what I dread, a thin film of matrix on some vague tissue, which is difficult to clean. So we spend a lot of time here going slowly over all these structures. So again, there is a big pocket of colostoma, deep one, not a big one, but a fairly deep pocket, I would say. So that's the undersurface of the carotid being cleaned, and whatever is there in that corner being drilled out. So it's not the bigger chunks that are important. It's all these smaller hidden areas that ultimately determine the success of your story, because if you leave behind even a small bit of colostoma, 10 years later, this patient will come back to you with the recurrence. Okay, so that's, you see, that's being brave on the carotid on the undersurface. I'm just using the knife directly on the carotid. So that much has been removed so far, but that's not all. Definitely that's not all. We move to the next clip, that is number 11. So we are removing that last bit going into the infratemporal fossa, which for me was a little irritating. I was not very sure if all of it would come out. But again, as I told you, fortune favors the brave. And there you see that last bit, you see, that is somewhere embedded into the infratemporal fossa tissues. We are in the upper neck now, okay? So around the area of the inferior petrosal sinus and those areas, you know. So it could bleed here, for instance. If it bleeds here, I would surely have to leave behind some matrix. So that's where you see sometimes you need to be lucky. And the matrix came out without me having to, and I know I saw some vessels here, you know. So I used a cotton ball over the vessels. I was very, very gentle, and now you see all of that area is now clear. I'm zooming in just to make sure there's something there. Yeah, that last bit, see, that all thing, the whole thing has to come out in toto now. I can't leave behind anything there, you know. So again, I'm using a cotton ball. So all of that has to come out in one go. And let's go ahead. This will take a long time because I remember spending a long time doing this. Yeah, eventually. So all of that came out. See, that whole area is now clean. Okay, and the whole thing has been separated now. So now we debunk. So now there's no point because all the hinged areas are all released, hopefully. And we go ahead and remove the bulk of the colostoma at this point of time. See, there we found one area where it was attached. You see, I'm pulling it out slowly, nicely. So those gentle actions for me are the most important steps of the surgery. I see a lot of people working on big giant colostomas, directly going to the colostoma, sucking out, and then struggling with the matrix. So that should not be done. I think what we need to do is to be careful and take out all the matrix like that. Carefully. That's the posterior fossa dura. Okay, let me run through this now. For those of you interested, you can contact me directly. I'll show you. So as I told you, I needed some additional exposure. So I'm drilling that bone around between the internal meatus and the jugular bulb, which is a very dangerous area. Okay, so that's the jugular bulb somewhere down there. And I'm creating some space to ensure that I don't leave behind anything in that pocket medial to the internal meatus. So that last portion of the colostoma is now being removed gently. Again, posterior fossa dura here. So this was the last attachment, okay, which has come out. No CSF in that area, although there was some amount of CSF around the internal meatus. So this is the last bit we have cleaned up. So I have seen that around the colostoma there will be a kind of a thick mucosal margin, you know, which generally exists around the matrix. Okay, so those things can be coagulated. So let's go forward and we remove the last pieces of colostoma. Again, you see one small hinged area. that has to be removed without, see, slowly, gently peeled out so that the whole thing comes out. You see how I did that? So I didn't pull it in such a way that a part of it is left behind on the in that medial parts, you know. So that's, I think we're taking a photograph here of the last piece coming out. So that was the piece being taken out. Carotid pulsations can be seen nicely. Now we will go ahead and show the last part, that is Osia. Okay, so I'll just show one final look at the cavity. Complete clearance. That's the last piece of bone in the petrous apex, the petrous apical bone. Carotid pulsation seen. Final check being done. Okay, there you see. Okay, complete clearance. Posterior fossa dura here, completely medial to the internal artery meatus. Internal artery meatus is here. Posterior fossa dura, you see the dural pulsations. This is all dural pulsations. Infratemporal fossa is around this area. This is the last piece of bone. And then finally, we do some more inspections. I clean just to make sure there's nothing there. I do all this. Is a little bit of, I don't know, some flakes came up. So if I remember correctly, you know, so all these precautions have to be taken. Eventually, you're left with petrous bone, internal artery meatus, cut facial nerve, carotid, and the posterior fossa dura, middle fossa dura here. Everything else has been completely removed. There is no lesion, cholestoma whatsoever, and we're checking the. I'm using the cotton ball on the posterior fossa dura. Okay, on the posterior fossa. Sorry. Okay, I'm using the cotton ball on the posterior fossa dura, and that's the elimination of the tumor and completion of surgical excision of petrous bone cholestoma. Now we get into the Osia part. Okay, and I'll quickly wrap it up. We've already been through the Osia implantation right in the beginning. Anyway, so we flush, we clean. So it's a perfect cavity, absolutely clear and devoid of any bit of cholestoma. Carotid pulsations, okay, dura pulsations, internal artery canal pulsations, middle fossa dura pulsations. Okay, everything else has been removed, excised. Okay, so again, last look at the cavity. Okay, fine. So that's the carotid. Fine. So now I'll show you Osia, how we did the Osia implantation. So we close the emissary vein. The first step is to close the emissary vein. You see the emissary vein bleeding there as we elevate the pocket. I close the emissary vein using coagulation. It has got a bony one end inside the bone, the other end inside the soft tissue. Okay. So once that is done, we keep the template and we see which is that point that was marked and what is the most convenient position for the template. Now again, this template placement, we put it in a very odd, it has to be either vertical, you know, it has to be up or down. So this placement of the template kind of corresponding to the curvature of the mastoid cavity again has not been described. So we have been the first ones to try out this position, and we were successful. Again, you know, fortune favors the brave. I was not very sure if we could get this to work. Let's go ahead again. So this particular positioning of the implant was necessary for us, and I was hopeful, and we eventually managed to get the template fixed in the first place, and then later on the implant as well. So here you see that the template is nicely fitting. Now this is a very retracted skin pocket, so we will be able to nicely put back the skin over this implant after the end of the surgery. So now we clean up the bone there where we want to insert the BI300 implant, which is the same as a Baha implant. So they developed the whole osseous system in such a way that it can be done over it can be put over the same Baha implant which has been there for several years now. Okay. So now we go into the second step. Share screen. Okay. So the bone has been completely drilled out, as you see. The bone has been completely drilled out. All the periosteum and whatever else was there. I was a little fearful about the emissary vein all throughout the Baha placement, and that's definitely a consideration when you do Baha for a lateral skull base surgery. And going forward, I think we will have troublesome emissary veins. But yes, we will always find a solution. So we keep the template and we mark the drilling point for Baha BI 300 implant to be placed. So that's the template positioning, and we mark the implant. So now what we will do is we will, okay, so that's the implant. Again, we have the guide drill and all those steps of Baha, which I think most of you know, guide drill being placed, and then we get a sink and a counter sink, and all those steps are as in a Baha surgery. So I'm just going to skip through this. See, a nice countersink has been achieved. We went in for a 4 mm this thing. Again, the skin thickness has been measured. A lot of things in Baha surgery which I don't think I have the time to explain. So at this stage, it's suffice it to say that we did a BI 300 placement with a 4 mm implant. So that's the countersink, and then we are placing the implant now using a drill again. So the drill speed is much slower now, and that's the lock. So the implant is in place. 2 times check lock again, and we have seen that when I remove the drill, we see that the implant is in place. This is the base implant, the Baha 3. We removed it because it was not perfectly aligned to the surface of the cortex. So we removed it and put it back again, probably angulation issues. And now we again got a perfect click, perfect this thing where the Baha stuck into the bone. So once that is done, the final step is implant Osia itself. So this is what is called the bone bed indicator. So this, oh sorry, I need to share this. This is what is called the bone bed indicator. Now the bone bed indicator, you see, has this projection which needs to be turned all around. So at that point, you see, now at this point, we found that there was some bony protuberance, which means that if the Osia is placed over this, the Osia implant itself would touch that part of bone, leading to a loss of conduction into the BI 300 itself. So what we have to do is drill out. So we gathered that we have to drill out this bony protuberance, which I'm going to do right now. See, I'm going to drill out that, and that's very close to the emissary vein. You see, this was kind of a cooperative emissary vein. So this time we were lucky to, you know, get away with the smallish emissary vein, which was within our control. But going forward, I expect bigger emissary veins, and this is one issue which needs to be tackled, and some solution needs to be found if there are bigger emissary veins around the area of the BI 300 implant. So once that was done, we then use the bone bed indicator, and in this case you can see that the bone bed indicator was, we were able to move the lateral, I would say the arm of the bone bed indicator all around without any problem. See, it's moving freely now, which means that if the implant is placed on this BI 300, there will not be any chance that the implant will lie on any bony projections. So if you see here, we are pushing it around. It's coming out nicely from the other side. It's coming out nicely, coming out nicely, coming out. So all around, it's moving nicely, which means there are no bony protuberances. Okay, so we removed that, and now we go into open the Osia implant. Now, as I told you, Osia implant itself has 2 parts. One is the magnetic coil, like the receiver stimulator complex in cochlear implants, and it has got a transducer which sits directly on the BI 300. So this transducer is piezo powered. So there is a screw that you'll have to pick up. There are 2 screws, 1 screw as a spare screw. So you take a screw, put it into this, and then push the, so you take that screw there, one of the screws, magnetic, push it inside, and then that has to be pushed into the BI300. So this Osia implant essentially sits on the BI300. What do you say? BI300 implant. Okay, so you see I'm pushing the screw in fully, and now I pick up the implant. Okay, so this is not a cochlear implant, so one need not be, you know, so precise in picking it up with forceps and stuff like that. So and then what we do is we now place the OSI 200, that is Osseointegrated Steady State implant. Oseo stands for Osseointegrated Steady State, and this screw goes on the head of the BI300 implant. Okay, so this is the final step. So we push the rest of the receivers, or I would say the magnetic coil component under the skin pocket, which we have elevated, and we have now completed the Baha implant, Osia implant, and we brought out, we just turned it according to our convenience and then tightened the screw again. So yeah, now we tighten the screw. Okay, so we keep it okay, so that's the final tightening of the screw being done, and now the Osia implant has been successfully screwed onto the BI300 implant, which is screwed onto healthy bone, which will lead to osseointegration of that implant with the bone. So this is all about it. The cavity is then again inspected. He must have achieved. Periosteum is used to close the eustachian tube defect, and as Ganga showed you earlier, I don't know if we have a video of the fat being put. Let me see. Otherwise, we have shown you pictures of how the fat is placed into the cavity. Yes, we have the video. So I'm going to share this screen with you to show you how we deposit fat. So yeah, we use fibrin glue to close the interlocutory meatus. Okay, so we don't want any CSF leak. We use fibrin glue to close the interlocutory meatus, and then use fat to plug the, or to close the cavity. So we need the fat to be nicely projecting out, bulging out, so that we put pressure when we what do you say, close the skin over the fat. So the closure is not shown here. So that's it, guys. That's all, folks, as we see in Disney videos. So thanks for being with us. Thanks for being a part of this case of the month. We'll be showing you more interesting cases as we do more surgeries. Now, this month has been a bad month for the whole of Bangalore. We've seen a lot of COVID cases, being diagnosed in the city. Bangalore is, in fact, one of the most badly affected cities in India, and we need to come out of this soon. So this month we don't have too many surgeries posted. All elective surgeries have been cancelled. We are having a month long. We've already had 10 days of lockdown, and we are going to extend our lockdown for the next 2 weeks. So nothing is going to happen as far as BSBI is concerned, as far as May is concerned. But we are going to show you something that we did in the last few months. As I told you, we do about a minimum of 8 to 10 skull-base surgery in most of the months around the year, and we will keep you updated. We will keep you educated, and please tune in to this space, and all the information that you need regarding our academic schedule program is available on our website as well as on our social media handles. Kindly be in touch with us for any information regarding our programs, and we'll be happy to provide you. Thank you, and God bless, and good night.